Today we'll be discussing all the important previous year topics which has been asked in your FMGE exams. So I'll be covering everything in rapid revision mode. So I'll be giving the PDFs for you. So once it is like during exams, you can go through this for revision purpose also. So the first topic which is very important is mortality indicators. So they'll be asking so many questions on mortality indicators for you. Very important topic. So the first thing is crude death rate. Crude death rate, the denominator is mid-year population. So the denominator is mid-year population. So when you are telling the risk of death in mid-year population, since the word crude comes, it is not age or sex specific. To frame this question, crude death rate is age or sex specific. If they ask this, it is wrong answer. Crude death rate is not age or not sex specific. So what is the denominator of crude death rate? Mid-year population. So it is risk of death in the whole population. But if I take risk of death in different age groups, so 0 to 5 years, how many are there? How many will die? 5 to 10 years, how many are there? How many will die? If I go like this, if I go through age or sex for males and for females, what is that death rate called as? Specific death rate. Either you mark it as age specific death rate or sex specific death rate. The only difference is crude is for the whole population. But specific death rate, you go either age-wise or sex-wise. So if I am asking this question, which of the following will represent risk of death in different subgroups? अगर ऐसे पूछेंगे ना आपको, which of the following will indicate risk of death in different subgroups? This keyword will be there. Then फिर आपका आंसर क्या होगा? फिर what is your answer? Tell me. Specific death rates. Very good. Crude death rates, it is for the whole population. Specific death rate, either it is age specific or sex specific. That will indicate risk of death in different subgroups. Then come to these two things. How to differentiate between proportional mortality rate and case fatality rate. So what is important is proportional mortality rate means a rare disease, like for example tuberculosis. We want to know the contribution of TB in terms of mortality. Then we make a pie chart. Out of total deaths which happened due to all the causes, in that TB will contribute how much? We make one pie chart. So contribution of TB in total deaths. If they ask what is the denominator of proportional mortality rate, what is your answer? Tell me good. What is the denominator of proportional mortality rate? Very good. It is total deaths. In that, how much TB will contribute? So it will indicate contribution of a disease in total mortality. So that is what they are telling. Burden of disease with respect to mortality, because denominator is total deaths. फिर उसमें हर एक disease का contribution you want to check. So what indicator is used? If this is the question, tell me the answer. Good. Proportional mortality rate. What is the mortality indicator which indicate burden of a disease? It is proportional mortality rate. Means this will indicate the most common cause of death. For example, if cardiovascular disease contribute to 40%, so out of total mortality, cardiovascular disease is contributing to 40%. So that will indicate the most common cause of death. If I want to know the most common cause of death, what indicator is used? If they frame this question, if I want to know the most common cause of death, what indicator is used? Proportional mortality rates. Good. Proportional mortality rates. Case fatality rates. Case fatality rates, as the word suggests, denominator will be cases, numerator will be death. Denominator cases, numerator death. In total case, like for example, if there are 100 cases, 30 died. 100 cases, 30 died. What is case fatality rate? What is case fatality rate? 30%. Remaining 70% will indicate survival rate. If case fatality rate 30% है, तो बाकी जितनी भी होगा ना, they survived. That is called as survival rate. 70%. So both will go opposite. Yes, case fatality rates and survival rate will go opposite. What is the use of case fatality rate? Killing power of a disease. How dangerous is the disease? If they frame this question, virulence of a disease or killing power of a disease, then your answer should be case fatality rate. What is your answer? Repeat. Case fatality rate. So don't confuse between crude death rate and specific death rates. Don't confuse between proportional mortality rate and case fatality rates. If they ask what is the importance of each standardized death rates and standardized mortality ratio, this can be asked in the exam. Just listen. If there are two populations with different age structure, if I am asking what is the difference between them, different age structure, two different populations with different age structure. One population is having more older age group. The proportion of older age group is more. In such situation, what you should use to compare mortality pattern? If this is the question, agar ye question aa gaya na, answer is standardized death rates. What factor you are standardizing for? Age. Age standardized death rates can be used to compare mortality pattern between two populations with different age structure. फिर what standardization we have to do? Direct standardization. Repeat the word, direct standardization. What we are doing in direct standardization is we are nullifying that effect. One is having more older age group, that area, that factor, we are neutralizing it by taking one standard population, So what you'll be doing in direct standardization is each specific death rates of two study population what you are comparing. What is direct standardization? Repeat. Each specific death rates of two study population is applied on one standard population. ये दो population का जितने भी each specific death rates होगा ना, फिर उसको एक standard population के ऊपर लगा देते हैं. That is direct standardization. Comparing or putting this each specific death rates of two study population on one standard population. This is direct standardization. What it will give? Each standardized death rates. What is the use of this? To compare mortality between two populations with different age structure. What is standardized mortality ratio? The formula it is given: observed deaths by expected deaths. They'll ask this question: observed deaths by expected deaths. So the formula is this, because already observed deaths is given in the occupation. For example, I'm telling coal miners. Coal miners will be the occupation. Observed deaths is given, for example, 9 per 1000. Observed deaths is given, that is 9 per 1000. If I want to calculate expected deaths, I have to do indirect standardization. What I am supposed to do? This is taking age specific death rates of standard population, applying on study population. Age specific death rates of standard population applied on study population to give expected deaths. After indirect standardization, if expected deaths is 7 per 1000, for example, I'm telling, take the ratio O by E. एक बार डिवाइड करो दोनों को, 9 by 7, it is more than 1. Standardized mortality ratio is more than 1. Means this occupation is having more risk of death. Yes, this occupation is having more risk of death compared to general population. अगर एक क्वेश्चन आ गया ना, what is used to compare mortality between occupation and general population, directly mark standardized mortality ratio. What is the formula? observed deaths by expected deaths. Already क्या है आपके पास? Observed deaths. What you want? Expected deaths. How we get indirect standardization? What is indirect standardization? Take the rates of standard population. Each specific death rates of standard population is applied on study population. Remember, this question is applied on study population to get expected deaths. When you take the ratio, if it is more than 1, this occupation is having more risk of death. So this slide what I'm discussing is very important. Come to the next part. What is the difference between incidence and prevalence? If they ask this question, what is the difference between incidence and prevalence? Both incidence and prevalence are morbidity indicators. Morbidity indicators. See the word English. Incidence means something will happen in the future. अभी नहीं है हमारे पास. It will happen in the future. New cases divided by population at risk. पहले क्या लोगे आप? What you will take first? Population at risk. Give some time. Follow-up should be done. Yes. Follow-up should be done. After certain time, how many new cases will develop? Yes. That is incidence. So new cases by population at risk. If they ask this question, this is the formula for incidence. If you take population now, do a follow-up for certain duration. Take population at risk. Follow-up should be done. The study is cohort study, where you do follow-up. If they ask this question, cohort study is used to calculate. If they ask directly, it is incidence. What is incidence? New cases. What is the denominator? Population at risk. So you are giving time component. Follow-up is being done. तो एक बार follow-up करोगे ना, it is rate. It is rate of occurrence of new cases or rate risk of developing disease. If they make this question, which of the following will indicate risk of developing disease? Answer is incidence. So repeat my words. Incidence is new cases. What is the denominator? Good. Population at risk. What we have to do? Follow up. What study? Cohort. What is this with respect to time? Rate. The risk of developing disease is given by incidence. Starting from exposure, you go towards outcome. That is what is written there. Cause to effect relationship. You start from exposure, go towards outcome. This sequence what you are studying is called as temporal association. Repeat my words. This sequence is called as temporal association. So if they ask what is temporality, starting from exposure going towards outcome. फिर एक बार आप smoking से शुरू करो. Now you are starting from smoking. You are going towards lung cancer in a study which is having follow-up, that is cohort study. This sequence what you are studying is called as temporal association. Means पहले ये आएगा बाद में वो आएगा. पहले क्या आएगा? एक्सपोजर, पहले स्मोकिंग, बाद में आउटकम, लंग कैंसर. दिस सीक्वेंस इज कॉल्ड एज temporal association. This is the most important criteria to prove etiology. If I am framing this question, which of the following is most important criteria to prove etiology? Answer is temporality. That is why what I am asking is, in order to prove etiology, if you want to prove etiology, we have to use incidence, cohort studies. Incidence will indicate etiology. अगर ये question आएगा ना, if they ask why, because there is temporality. What is temporality? Exposure to outcome. Means you can tell smoking is the risk factor. It will help in assessing what are the risk factors which can lead to disease. If they ask this question, you are eliciting risk etiology. What is preferred? If they ask incidence or prevalence, what is your answer? Incidence. Don't mark it as prevalence. Now come to this part. Existing cases. At one point of time, if you are going and doing a study, existing cases at one point of time. If they ask this, existing cases at one point of time is what study? Cross-sectional study. Cross-sectional studies will give what? If they ask this question directly, cross-sectional studies will give prevalence. That is, how many are having disease at one point of time. How many are having disease at one point of time? Like for example, if you go and do a pie chart, at one point of time, how many are having disease? This is cross-sectional study. What is the main thing which is missing in cross-section? As the word cross-section indicates, it is at one point of time. It is done at one point of time. So since it is proportion, the percentage of diseased individuals, there is no follow-up. You cannot prove etiology. There is no temporal association. There is no temporality. That is why you cannot prove etiological hypothesis. What is temporality? Exposure to outcome. That is not proved using cross-sectional study. We get only prevalence. It is not a measure to study how they develop disease. It will tell how many are having disease. That's it. It will not tell how they developed disease. How they develop disease is totally different thing. It will tell only burden. Which of the following is morbidity indicator? If they frame this question, which of the following is a morbidity indicator which can indicate burden of disease? Answer my question. Prevalence. Mortality indicator for burden of disease. Yes, mortality indicator for burden of disease. Proportional mortality rate. Proportional mortality rate. Don't confuse between these two things. Here the study is cross-sectional study. All at one point of time. Prevalence depends on duration of illness means what? You know the equation, repeat with me, very good. Prevalence depends on duration of illness ka matlab, what is the answer? Yes. P is equal to I into D. D for duration, I for incidence. If prevalence depends on two things, incidence and duration, duration of illness. Duration of illness depends on two factors, cure and death. Duration of illness depends on two factors, cure and death. So if I am asking duration of illness depends on how many factors? Two. Tell me the factors on which duration of illness depends. Cure and death. If the disease is having more cure or more fatality, tell me, if the disease is having more cure and more fatality, the disease is acute illness. Acute illness will be having less prevalence. Yes, acute illness will be having less prevalence. But what type of illness will be having more prevalence? Long-standing illness. Give some examples for long-standing illness. Yes, correct. Very good. Diabetes. Yes, very good. Hypertension. Yes, correct. These diseases are chronic diseases. Chronic diseases will be having more prevalence. So if they frame this question, prevalence of disease depends on duration of illness, answer is correct. So got my point? Keep this equation. P is equal to I into D. So based on this, they'll ask so many questions like what will happen if a new treatment comes? What will happen if a new treatment for cancer comes? If they give direct questions like this, if they give direct questions like this, you should remember these things. So what I want to tell is, see this question. So how the question comes is, prevalence depends on duration of illness. So based on this, they're asking this question. So take this question. A new effective treatment for cancer means something which is non-communicable disease, which is giving cure. A new effective treatment for cancer. So what will happen if cancer cures? If I'm asking questions like this, what will happen if cancer cures? It is not having any effect on incidence. Incidence will not change because you are not preventing anything. Incidence will not change because you are not preventing anything, but prevalence will decrease. Existing cases will come down. That is the importance of surgical intervention. If they ask questions like this, surgical intervention, mass screening for any cancer, and you are taking them to hospital and you are making them cure, you are giving them cure, like what is the advantage of this? Incidence will not change, prevalence will decrease. But the question, if it is twisted like this, don't make mistake in this question. एक बार question देखो what they are asking. A new treatment for cancer prolonging the survival का मतलब duration is increased. There is no cure, but यहाँ पे what is happening, you are prolonging the survival, the duration is prolonged, incidence will not change, same, you're not preventing anything, but prevalence will increase. Prevalence will increase. It will help, like the duration of disease is prolonged, no? So prevalence will be more. Prevalence will be more. So if they frame this question, chemotherapy, surgical intervention, see the words properly. Surgical intervention means cure. Prevalence will decrease. Prevalence will decrease. Prolonging the survival means duration is increased. So one side prevalence will decrease, the other side prevalence will increase. In case if the question comes on communicable disease, एक बार इसको highlight करो, good. I'll be giving everything, I'll be giving the PDFs for you, whatever I'm using here. So a new effective treatment for communicable disease, tuberculosis, का मतलब the patient is getting cure, at the same time transmission is reduced. So both will decrease, prevalence will decrease, incidence will decrease. Why incidence will decrease? Because transmission is reduced. You are treating a communicable disease, so transmission will come down. Yes. A new prophylactic intervention means something which is preventive. Prophylactic intervention will reduce incidence. If incidence is coming down, prevalence will also decrease. P is equal to I into D. If incidence is decreasing, prevalence will also decrease. So the question was a new prophylactic intervention like chemoprophylaxis or immunoprophylaxis. Chemoprophylaxis means drug. Immunoprophylaxis means vaccine. So what is the advantage of all these things? It will reduce two things. Incidence will also come down, at the same time prevalence will also decrease. So keep this question in mind. A new prophylactic intervention, what will happen? So the question 1, 2, 3, 4. Usually what the examiner is fond of is this question. So this session is for rapid revision session. So I'm bringing all the important topics in a rapid revision mode, so that once just before the exams, we are creating this mode of rapid revision so that you get hold of all the important topics which has been asked in your exams. So how to differentiate between the index, what is asked in the exams. Don't make mistake in this table. This is very, very important table for you. Human Development Index, Physical Quality of Life Index, Multi-Dimensional Poverty Index, and Global Hunger Index. So repeat the words: Human Development Index, Physical Quality of Life Index, Multi-Dimensional Poverty Index, and Global Hunger Index. So these are very, very important things. So what they're asking for you in the exams, especially the index part. So here one by one, Human Development Index has 3 dimensions. Repeat with me. Human Development Index has 3 dimensions. One is knowledge, second is income, third is longevity. One is knowledge, K, I for income, L for longevity. So the mnemonic is skill. If they ask how many dimensions are used, 3 dimensions. But how many indicators are used? Mean years of schooling, expected years of schooling. पहले क्या था ना इसके अंदर? Literacy rate was used. Now it is not used. Remember this. Gross enrollment ratio was used. Now it is not used. So we are having 2 things: mean years of schooling and expected years of schooling. So repeat the words. Yes, mean years of schooling and expected years of schooling. What is the income parameter? Tell me, repeat. Very good. Not GDP. Yes, what you are telling is good. Not GDP. It is GNI, gross national income. दोनों में फर्क है ना? There is a difference. What we produce, that is GDP. What extra help we get from foreign countries, that is also very important. Like our PM is going to countries, bringing, like all the countries are funding, they are bringing some investment. If this is the question, extra thing what is added into GDP, both together, दोनों मिलाने के बाद it will become GNI, gross national income per capita. Longevity is life expectancy from birth. So how the country will B, like the standard of living. If I'm asking what is used to compare standard of living between countries, see the question properly. What is used to compare standard of living between countries? So what is your answer? Yes, human development index, human development index. If they ask question, what is used to compare quality of life? The first is standard of living. Second is what is used to compare quality of life? Infant mortality rate, literacy rate, and life expectancy at age 1. The answer is ill. Infant mortality rate, literacy rate, and life expectancy at age 1. So what is missing if they ask directly? Income is not included. Income is not included. Income is not a part of PQLI. Income is not considered under physical quality of life index. So keep this in mind. So what is used for standard of living? Tell me. Human development index, where income is included. What is included? What is used to compare quality of life? PQLI, physical quality of life index, where income is not considered. Income is not considered. Multi-dimensional poverty index, MDPI. See the words properly. Multi-dimensional poverty index. So we have three things. Tell me the mnemonic. HEL, hell. Very good. Hell, poverty. Remember like this. What is H in this? Health. What is E? Education. What is L? Living standards. So what are the two things we consider in health? Child mortality and nutritional status. Child mortality and nutritional status. What is considered under education? Years of schooling and school attendance rate. Remember this word. Years of schooling and school attendance rate. What is included in living standards? Cooking fuel, what we are using. Water facility, yes or no in the house. Toilet, yes, very important. Sanitation. Electricity, floor, assets. So total, how many dimensions? If they ask multi-dimensional poverty index, total how many dimensions? Repeat my words. 3 dimensions. Health, education, living standards. Tell me the word. H for health, E for education, L for living standards. Hell is the mnemonic. 3 dimensions are there. But if I'm asking how many indicators are there, okay, yes, good. कितने indicators? एक बार गिन लो. 2, 2, 6. Yes, sir. 3 dimensions for 10 indicators. So repeat my words. 3 dimensions, 10 indicators. Nutrition chapter, very, very important, is Global Hunger Index. Global Hunger Index considers what? Proportion of undernourished population, under 5 wasting indicating acute malnutrition, and under 5 stunting indicating chronic malnutrition. One is for acute and the other is for chronic. Then we count under 5 deaths. So everything within under 5. The first indicator is proportion of undernourished population. Then comes child undernourishment. With child undernourishment, we are checking 2 things. Wasting and stunting. We are checking 2 things. Repeat the words. Wasting and stunting, and under 5 mortality. This is the way to calculate global hunger index. This is the way to calculate global hunger index. Very important point is what is the difference between when you are calculating 3 things. What is the difference between dailies, qualies, and hills? So if they ask these words, what is the main difference between dailies, qualies, and hill? Just listen to the words properly. Starting from birth till death. Starting from birth till death. If the sequence is like this, birth till death, that is standard life expectancy. Standard life expectancy. If the person is living like this, in between something happens to the individual, disability starts, and he is living with disability till this point. Living with disability till this point. This is years lived with disability. Years lived with disability. Death before attaining that standard limit. So whatever we lost is years of life lost due to that disease. So we count both YLL plus YLD, years of life lost plus years lived with disability, that will indicate days lost in this individual due to that disease. One more individual you take, for example, you are taking arthritis. There are different patients with arthritis. Every patient is having their own YLL and YLD. What is YLL? Years of life lost due to premature death. What is YLD? Years lived with disability. Years lived with disability. So add both the components. YLL plus YLD. You add both YLL plus YLD. That will give dailies for this individual. Like bring all the patients together and study dailies lost due to that disease. Then compare which disease is having more burden in the community. What is the use of dailies? To say, to express burden of disease. So repeat my words. What is the use of dailies? To express burden of disease. What is the formula? YLL plus YLD. Dailies is equal to YLL plus YLD. Years of life lost plus years lived with disability. When you compare both the things, you'll be getting dailies lost in that disease. So there are two diseases. When you compare A and B, more the dailies lost, that disease will be more burden. For example, A 80 dailies lost, B 60 dailies lost. A 80, B 60. Then A is having more burden comparatively. More the dailies lost, more the burden of disease. But what is QALY used for? To tell how good is the intervention. The indicator to express effectiveness of intervention. Remember the word effectiveness. Effectiveness of intervention, if they use, we have to use QALYs given, QALYs gained. This is the indicator used. Repeat the words. QALYs gained. More the QALYs given, better is the intervention. We consider both quantity and quality of life. How good is that intervention? That is decided by quantity of life given by that intervention, at the same time quality of life. Quality of life, there is a way to assess it. There is one value that is called as utility value. Based on that, we tell how good is the intervention. The intervention should give more quantity, it should prolong the life, at the same time it should give good quality also. Then that intervention will be better comparatively. So what is the parameter? Tell me very good. What is the parameter to assess effectiveness of intervention, considering both quantity and quality of life? If the question comes like this, your answer should be QALYs given by that intervention. Then come to this word health adjusted life expectancy. The number of years an individual can live in full health means, if this is the total life expectancy, if something has happened, negativities, that is what life is. Something will happen in between. We subtract everything. Only the positive point is counted. Only the positive component is counted. Only the positive component is counted. That is telling how good, like how well the person has lived in that population. Every population is having different health adjusted life expectancy. If burden is less, health will be more. See the words properly. If burden of disease is less, health will be better. Health will be better. So number of years an individual can live in full health. See the words properly. Full health. Number of years an individual can live in full health means, that means if negativities is less, health will be more. For male, for females we count separately. What is health for this population? That means burden should be less, better we live. Before, this word was taken as disability free life expectancy. We don't use that word now. Disability free life expectancy. This was the word used. Now it is not used. What was the older word? Disability free life expectancy. We are not using that. That has been replaced totally by DALE. Disability adjusted life expectancy. And that has been replaced totally by HALE now. Health adjusted life expectancy. So this is the newer word. Health adjusted life expectancy. Coming to this table, which is very, very important for you, that is National Immunization Schedule. So repeat with me, what is this table dealing with? National Immunization Schedule. What we say it as Mission Indradhanushna, National Immunization Schedule. So tell me what is given at birth. So repeat with me, what is given at birth? BCG, OPV 0 dose. What we give at birth, OPV is called as OPV 0 dose. Hepatitis B birth dose. Hepatitis B birth dose is compulsory for all the newborns in India. Remember this word. Hepatitis B birth dose is compulsory for all the newborns in India. In case if the mother is HPSAG positive, the newborn will get vaccine plus immunoglobulin. The newborn should get, repeat, vaccine plus immunoglobulin. 6 weeks, 10th week and 14th week. So there is a gap of 4 weeks in between them. 6, 10 and 14. So repeat the words. There is a gap of how many weeks? 4 weeks. So what they are giving? OPV and pentavalent. So all the states of our country has introduced OPV and pentavalent. OPV first dose, OPV second dose and OPV third dose. So repeat the words. OPV 1, 2 and 3. Pentavalent 1, 2, 3. So what will be the gap between 2 doses of pentavalent vaccine? This is the question. What will be the gap between 2 doses of pentavalent vaccine? So answer is 4 weeks. We have to keep a gap of 4 weeks between 2 doses of pentavalent vaccine. Then comes Rota, IPV, PCV. So repeat the words. Rest in peace. Rota, IPV, PCV. What IPV is used? Fractional IPV. Very good. Fractional means dose is less. We give intradermally. That is fractional IPV. When IPV was introduced, पहले जब introduce हुआ था ना, उस time पे we are giving intramuscular. That is not. We are using fractional now. It is intradermal. And PCV. Pneumococcal conjugate vaccine. So first dose, second dose, third dose. Again IPV, first dose is there, second dose is there, third dose we have introduced. PCV, first dose, second dose and there is booster. So almost if you can remember 3 vaccines, rest in peace, Rota, IPV, PCV, in तीनों का 3 doses है. Just keep it in mind like this. Rota 1, 2, 3, fractional IPV 1, 2 and 3, yes, IPV. And PCV 1, 2 and booster. PCV 1, 2 and booster. What is PCV? Pneumococcal conjugate vaccine. So then come 9th month, which is very, very important milestone for a child. The child should get measles vaccine. So most of the states have shifted to MR vaccine. MR first dose is given at 9th month. Vitamin A at 9th month, it is 1 lakh international units. Repeat, vitamin A at 9th month, it is 1 lakh international units. Japanese encephalitis first dose. You know this, Japanese encephalitis is used only in endemic areas. Some states are using live vaccine and some states have started using killed vaccines also. JE live, it is subcutaneous. JE killed vaccine, intramuscular. There is a difference in the route of administration. JE live, subcutaneous, JE killed, intramuscular. 16 to 24 months. 16 to 24 months. DPT first booster. Yes, because DPT was a part of pentavalent before. Now we are using DPT first booster. OPV booster. DPT first booster and OPV booster. Along with this, measles second dose. So as I told already, measles second dose is given in the form of MR second dose and Japanese encephalitis second dose. So Japanese encephalitis is used only in endemic areas. So keep this in mind. It is used only in endemic areas. Then come to 5 to 6 years. What is used in 5 to 6 years? Tell me very good. DPT second booster, DPT second booster. So DPT first booster, 5 to 6 years we are using DPT second booster. Then comes TD vaccine. TD vaccine. So we are targeting more of FMG topics here. So this is dedicated to FMG session. We are targeting only FMG topics. So all the important topics I'm targeting here. So TD1 and TD2. So TD1 and TD2, 10 years we're using TD1 and 10 years and 16 years we're using TD2 doses. So how many doses of TD? 2 doses. Good. Then come to pregnancy. TD1 and TD2 means we are giving 2 doses of TD at a gap of 4 weeks. So repeat the words, 2 doses of TD at a gap of 4 weeks. Then comes booster. If there is pregnancy within 3 years after taking vaccine, yes, fine. Again, if she is pregnant within 3 years, she has to take booster. Means she was previously vaccinated with 2 doses of TD. Good. 2 doses of TD I'm telling. Yes. Then if she is pregnant within 3 years, she has to take booster. After 3 years, if she is pregnant, she has to take 2 doses again. What is the role of booster? Only if she is pregnant within 3 years. After 3 years, she has to repeat 2 doses. Very important table, that is vaccine related side effects. So remember the words vaccine related adverse effects. This question is repeatedly asked for you in the exams. Vaccine related adverse effects. So what I am telling here, one by one, BCG. BCG can cause 3 things usually. One is suppurative lymphadenitis. Yes, lymph node with abscess, suppurative lymphadenitis. The gap is 2 to 6 months. After you receive vaccine, the gap will be 2 to 6 months. For BCG osteitis and disseminated BCG infection, the gap will be 1 to 12 months. So what is happening in BCG osteitis? There is bone involvement. Disseminated BCG infection means symptoms similar to tuberculosis, symptoms similar to TB. There will be fever, weight loss. See the words properly. Disseminated BCG infection, there is symptoms similar to tuberculosis. There is fever, weight loss, and chest infiltrates. So these 2 side effects, BCG osteitis and disseminated BCG infection, will happen after how many months of BCG? 1 to 12 months. Measles or MR or MMR vaccine. Measles, MR or MMR vaccine can cause febrile seizures, thrombocytopenia. Important, they can give it like this: ITP, immune thrombocytopenic purpura. They can frame questions like this: ITP, immune thrombocytopenic purpura, or encephalopathy, and toxic shock syndrome. So this question will come for you in the exam. Toxic shock syndrome, how it presents? Toxic shock syndrome, how it presents? It will present as fever, diarrhea, shock. Death usually within 24 to 48 hours. If they give this question, you are going to a village, you are giving one vaccine. After that, there is cluster of children complaining of fever, diarrhea, shock. So if they mention these 3 words, listen to the words properly: fever, diarrhea, shock, and death within 24 to 48 hours. This is toxic shock syndrome, which is usually seen in measles vaccine compared to BCG vaccine. This is usually seen in measles vaccine compared to BCG vaccine. Oral polio vaccine, which is live attenuated vaccine. OPV, which is live attenuated vaccine, when it is given to a child with congenital immunodeficiency. See the words properly. When it is given to a child with congenital immunodeficiency, what will happen? There is chance of paralysis in the child who has received oral polio vaccine. That is called as VAP. Vaccine associated paralytic polio. See the words properly. Vaccine associated paralytic polio means the child has received OPV and it is causing paralysis. Live vaccine causing paralysis is called as VAP. Vaccine associated paralytic polio. Why it happens? Only when there is congenital immunodeficiency. Usually it will not happen. Rarely it will happen when there is congenital immunodeficiency. The question in the exam will be, today if you are giving oral polio vaccine, within how many days? Means how many days it will take for VAP to present. So it is 4 to 30 days. Keep this in mind. It will take how many days? 4 to 30 days for VAP to present. Whole cell pertussis. Keep this in mind. We have DPT vaccine. What is DPT? P for pertussis. Whole cell pertussis, if you are using, it is neurotoxic. Chances of side effects will be more when you are using whole cell pertussis. Persistent inconsolable screaming. The child keeps on crying for more than 3 hours. Seizures, that is febrile seizures. Hypotonic hyporesponsive episodes usually happens within 0 to 48 hours. The child is hypotonic hyporesponsive. These episodes usually happens after DPT vaccine. It is self-limiting, nothing to panic. Encephalopathy. So what will happen if there is serious complications like screaming, encephalopathy, high grade fever or seizures? In the future, we are not repeating pertussis component in the child. We are giving only DT vaccine. If there is serious complications like screaming, hypotonic hyporesponsive episode, sometimes it will not be mentioned, it is not a contraindication, but there is encephalopathy, febrile seizures, these are the contraindications. We don't repeat pertussis component in the future. Tetanus, toxoid or TD, the side effect is brachial neuritis. So these are some important side effects which is repeatedly asked in the exam. For me, toxic shock syndrome is important. Toxic shock syndrome is important. Open vial policy. So I'll be knowing this. What is open vial policy? To reduce vaccine wastage. To reduce vaccine wastage. Anything which is opened, if the vaccine vials is opened, before opening we have to mention date and time. So keep this in mind. Before opening we have to mention date and time. So because if I can use it, if open vial policy is applicable, you can use it for the next sessions also. For 4 weeks you can use it. That is why I mentioned date and time, and you can use it for 4 weeks, 28 days that you can use it. What is the main advantage? You are reducing vaccine wastage. You are reducing vaccine wastage. Conditions that must be fulfilled before using that vial. You see the words properly. Conditions that must be fulfilled before using that vial. Expiry date has not passed, that is common sense. Cold chain is maintained properly. Vaccine vial septum has not submerged in the water, means it is not contaminated. We have maintained aseptic techniques. We have maintained aseptic techniques, and VVM has not reached the discard point. So how many stages of VVM we have? Repeat. 4 stages. 1, 2, 3, 4. In what stages you can use vaccine? 1 and 2. In what stages we cannot use vaccines? 3 and 4. So if it is in 1 and 2, you can use it. But the thing is, this open vial policy is not applicable to, means you cannot use what vaccines in the next session. Tell me, repeat. Very good. Yes, correct. Yes, very good. BCG diluted. Measles or MR diluted. JE live, you cannot use it. Rotavac, new update is you can use it in the next session. Keep this in mind. Intentionally I'm keeping that because still most of the textbooks or most of the books they're writing like this. Rotavac, now it is applicable. You can use it in the next sessions. So just keep this in mind. You can use it in the next session. Covishield, Covaxin, you cannot use it in the next session. So JE live, you cannot use it, but Rotavac, Japanese encephalitis killed vaccines, which is liquid, you can use it in the next session. So what is not used? Rotavac, it is used now. Before it was not used in the next session. Now we are having multi-dose vials. So for example, now remember like this, not applicable to BMJ. British Medical Journal. J for JE Live. Keep it in mind. JE Live is diluted because there is a diluent. We are using phosphate buffer saline to dilute. For that, if it is diluted, you cannot give it in the next session. We have to use these vaccines within the same day. Now, Rotavac can be used in the next session. JE killed can be used in the next session. So, open well policy question will come. So, see this point, very important. See this point, very, very important. So, when I discuss this, I'll be telling what is what. Just listen to me. Very good. First and foremost point is natural history of disease. What is natural history of disease? How disease will progress. How disease will progress. Starting from risk factor. Then you go to disease. After disease, you check for complications, how they die. The whole sequence where you are going in a forward direction. That is natural history, means course of a disease without any intervention. Studied by using cohort study. If cohort is not in the option, you can mark longitudinal study. If cohort is not in the option, it is longitudinal study. Level of prevention in pre-pathogenesis phase. What is happening in natural history? There are two phases, pre-pathogenesis phase and pathogenesis phase. Pre-pathogenesis phase means there is epidemiological triad. What is epidemiological triad? Agent, host, environment. They are interacting with respect to each other. Agent, host, environment. So when they are interacting with each other, agent, host, environment, when they are interacting with each other, there is risk factor. Agent is present. That is why we need to take primary levels of prevention. Take vaccine, take or use mask, or else you might get that agent within you. I don't want invasion. If the agent starts invading me, pathogenesis phase will start. First, the agent will invade into the body, that is infectivity. Later, the agent will produce illness, that is pathogenicity. What is the ability of an agent to invade and multiply? Infectivity, good. What is the ability of an agent to produce illness? Pathogenicity. So there will be illness, there will be death also. All this will come under pathogenesis phase. Infectivity, pathogenicity and virulence. All this will come under, yes, pathogenesis phase. In pathogenesis phase, we need to take secondary levels of prevention and tertiary levels of prevention. If there is illness in the body, we have to detect, diagnose, screening, that is secondary level. After complications, we have to improve quality of life, that is tertiary levels of prevention. So we need to do, yes, primary levels in pre-pathogenesis phase, secondary and tertiary levels in pathogenesis phase. What is an indirect estimate of incubation period? First there is exposure, then there is symptoms. This is incubation period. First there is exposure, then there is signs and symptoms. This is incubation period. But my point, now the question is, what is indirect estimate of incubation period? That is serial interval. What is serial interval? Gap between primary case and secondary case in the family. Today there is primary case, after certain time there is secondary case. That gap is called as interval. Nothing but serial interval. That is indirect estimate of incubation period. First there is exposure, then there is signs and symptoms. Nothing but incubation period. So if they ask this question, serial interval is an indirect estimate of, repeat the words, serial interval is an indirect estimate of, what is the answer? It is an indirect estimate of incubation period. What is used to calculate secondary attack rate? What is used to calculate? We are using the formula secondary cases by susceptible contacts. Within susceptible contacts in the family, yes, how many secondary cases will develop? I'll give the PDF for you, don't worry. I'll give the PowerPoint. You just listen to the class, answer my question. I'll give the PPT which I'm using here, so don't worry. So what is the formula for secondary attack rate? Tell me. Secondary cases divided by susceptible contacts. So if there is more secondary cases, the disease is more communicable in the family. Means susceptible contacts exposed to primary case, in that how many will develop disease. So they'll become secondary cases because after exposure to primary case, you're developing the disease. The formula is secondary cases by susceptible contact. So what is the formula? S by S. So what is used to estimate communicability of a disease? Within close contacts, usually family, classrooms, close contact, if they mention, it is secondary attack rate. Number of cases generated by one case when a population where all the individuals are susceptible to infection, means everyone is susceptible. New disease, how it spreads. I want to know the spread of new disease in a susceptible population. What is used? Basic reproduction number. The way of expressing this is R naught. R naught is basic reproduction number. If R naught is more than 1, it leads to epidemic. Outbreaks will happen. It is very difficult to control if the cases, means number of cases generated by one case in a completely susceptible population. Iceberg will not indicate or not include, the submerged portion will not include healthy population, because iceberg has two parts. Floating tip. What is floating tip? Repeat. What is floating tip? Clinical cases. What is floating tip? Clinical cases. What is submerged portion? What is submerged portion? Submerged portion is including carriers and latent infection. We have discussed that part. Carriers and latent infection. Submerged portion will not include healthy population. So repeat this word. Submerged portion will not include healthy population. What is pseudo carriers? What is pseudo carriers? Pseudo carriers means those who are having avirulent agents. If they mention this word, those who are carrying avirulent organisms, those individuals are called as pseudo carriers. Irregular AFASA distribution of cases is called as sporadic. Last year, the cases was in January and February, for example. Last year, the cases was in January and February. But in this year, if the cases happens around November, December, means there is no irregularity is not there. It is irregular distribution. You cannot predict anything. What is that transmission called as? If they mention this word, it is scattered distribution of cases. It is called as sporadic. Cyclical variations in measles is due to herd immunity changes. There are three things. MRI. Measles, rubella, influenza. See the words? Diseases showing cyclical trend. Measles, rubella, influenza. So what is MRI? Measles, rubella, influenza. Three diseases which show cyclical trend. Three diseases which show cyclical trend. Because there is changes in herd immunity, susceptibles will increase, epidemics will happen. Influenza pandemics is due to antigenic shift. But if the question is asked why there is cyclical variation in measles, then your answer is changes in herd immunity. Changes in herd immunity. Now see this question. What is the definition of incubation period? Tell me good. What is the definition of incubation period? Incubation period is gap between exposure to signs and symptoms. The gap between exposure to signs and symptoms. That is first sign and symptom. The gap between exposure to first sign and symptom. They mention this word. Nothing but incubation period. What is the way to calculate incubation period? Serial interval. What is serial interval? Gap between primary and secondary case. So if they ask indirect estimate of incubation period, see my words properly, indirect estimate of incubation period, then your answer is serial interval. Serial interval. What is median incubation period? What is median incubation period? Time taken from exposure to 50% of the cases. Today there is exposure. There is one way which happens, that is point source epidemic. after exposure, how many days it will take for 50% of the cases to develop. This is called as median incubation period. Median incubation period. Gap between exposure to maximum infectivity. Don't make mistake. Exposure to first sign and symptom is incubation period. Exposure to maximum infectivity is generation time. For example, today there is exposure. After 10 days there is fever. 14 days there is rash. After 10 days there is fever. 14 days there is rash. Exposure to 10 days. First sign and symptom is incubation period 10 days. But at the onset of rash, the child is highly infective. So exposure to maximum infectivity is 14 days. Incubation period will become 10 days. Generation time will become 14 days. Usually for some diseases it will be equal. On the first symptom only there is high infectivity. Then it becomes equal, but not for all the diseases. For very few diseases it is roughly equal to incubation period. So now repeat, what is incubation period? Exposure to first sign and symptom. What is exposure to 50% of the cases? Median incubation period. What is exposure to maximum infectivity? Generation time. What is gap between primary and secondary case? Serial interval. What is indirect estimate of incubation period? Serial interval. The time around which the patient is communicable, that is called as period of communicability, which will help in isolation. Period of communicability helps in, if they ask this question, it will help in isolation. It will help in isolation. What is latent period? Usually used for non-communicable diseases like diabetes, hypertension. For example, patient is having slight symptoms today, but he won't come to the hospital. Disease has started in the body. For example, cancer. He is having slight loss of appetite. Patient will not come to the hospital. But after 5-6 years, he is not able to swallow anything. Pain abdomen, complete emaciation. The gap which has taken, that gap between disease initiation, the disease has started, but how many days after the disease will detect? Disease will be detected. ये जो gap है ना, that gap is called as latent period. The word latent period is used usually for non-communicable diseases. Next, very important table. Very important table. Very easy to recall also. So now tell me one by one. I want you to differentiate study designs. I want you to know when they give the example in the exam, I want you to differentiate study designs. So what is one study, what you'll be studying called as? They ask this question. One study, what you'll be studying is called as. There is a new disease, atypical disease. One study you'll be studying. What is that study called as? Case study. A 10-year-old present with all these atypical manifestations. If they mention this word, a 10-year-old child presents with fever, rash after an exposure to radiation. Something atypical history is given. That is case study, also called as case report. See the words properly. What is one more name for case study? Case report. If I take multiple cases, if there is one case study, if I take 3-4 cases, 3 to 4 cases of pneumonia of unknown etiology, if they make this question, 3 to 4 cases of pneumonia of unknown etiology was reported from Wuhan city, China, which happened long back, na? Atypical, first time it happened. That is case series, case series. These two things, case study and case series. Case study and case series. These two things will come under, yes, good, tell me. These two things will come under descriptive study. Yes, very good. Case study and case series. ये दोनों है ना, it will come under descriptive study, where there is formulation of hypothesis. What is the use of descriptive studies? formulation of new hypothesis. Doing study at one point of time. We have discussed this point. Doing study at one point of time. Cross-sectional study. What cross-sectional study will indicate? Prevalence. What prevalence will indicate? Burden of disease. So out of 100, how many are having disease? You can make a pie chart like this. Out of 100, how many are having disease? That will indicate burden. So what is the use of cross-sectional study? Comparing the burden of diseases between two populations. If there is population 1, population 2, you can compare the burden of disease between two populations. Case control study, we take a comparison group. See the words properly. 3 words are there. Case control study. Case series means only cases are studied. Yes, good. Only cases we study. But in case control study, along with cases, we also take controls. Along with cases, we also take controls. So first step is cases with disease, controls without disease. How the study starts? The study starts with a question like this. There is comparison between two groups, diseased individuals and non-diseased individuals. Very important thing is matching. When you select controls, see the words properly. When you're selecting controls, we have to select in such a way that they are similar to cases with respect to certain factors like age, sex, occupation. We don't want those factors to play a role in disease formation, so we match them. Confounding factors are neutralized. If they ask question like known confounders which can influence the outcome, if they are neutralized in case control study, what is the step we use to neutralize known confounding factors? It is matching. After cases, we select controls by doing matching. So 3 steps we finished. Next is study. We ask exposure. Both the groups we are comparing, like how many are exposed in cases, how many are exposed in controls. Exposure in case and exposure in controls. Cases usually recall their exposure better compared to controls. If this word is there, cases will recall their exposure better compared to controls. अगर ये word पूछेंगे ना आपको, cases will try to recall the exposure better compared to controls. This bias is called as recall bias. So repeat the words. Cases will try to recall the exposure better compared to controls. This bias is called as recall bias. Good. Analysis, when we do, we calculate odds ratio. After doing study, we have to analyze the results. Analysis, we use odds ratio. For example, if I am writing like this, disease present, absent, out of 100, 100. 100 cases, 100 controls. Example I am telling. 100 cases, 100 controls. How many are exposed you are writing? Yes, no. 80, 20. Out of cases, 80% exposure. Out of controls, 20% exposure. Then fill the other values. So A, B, C, D. Odds ratio is AD by BC. We get 16. Cross product ratio. Now we have discussed everything in the class. This is just a rapid revision session for all the FMG going students like aspirants. Good. So A, B, C, D, when you make it is AD by BC. Cross product ratio. Very good. 16. It is more than one positive association. So tell me how to calculate odds ratio. Cross product we take in the table AD by BC. Total how many steps? 5 steps. Case, control, matching, exposure, odds ratio. Case, control, matching, exposure, odds ratio. Now come to cohort study. Now come to cohort study. So what we do in cohort study is we select two groups, exposed group and non-exposed group. Like exposed to risk factors, smoking, they will become smokers. Non-exposed group will become non-smokers. So smokers and non-smokers. Two groups you'll be selecting. Smokers and non-smokers. Two groups you'll be selecting. So after selecting two groups, you'll be comparing them. So what you'll be comparing? You'll be comparing the exposure pattern. Exposed versus non-exposed. Follow-up should be done. Loss to follow-up will happen. Dropouts will happen. That is attrition bias, which is seen in cohort study. Attrition bias is seen in cohort study. Analysis, when you calculate, we use incidence. New cases, we calculate risk ratio. What is the formula for odds ratio? ED by BC. But what is the formula for risk ratio? Incidence in exposed divided by incidence in non-exposed. We are comparing two things, risk in smokers divided by risk in non-smokers. If it is more than one, positive association. If the risk ratio is more than one, it is positive association. Now see this table. Let us compare case control study and cohort study in detail. So let us compare case control study and cohort study in detail. Okay, what is case control study? See the words properly. What is case control study? It starts from effect, go towards cause. It is retrospective study. Means you are taking the history of exposure. You are starting from effect, ask for exposure. You take two groups cases, you take controls, then you compare the exposure pattern. How many are exposed in case? How many are exposed in control? So the study is going in a backward direction. So it is retrospective study. Good. You are comparing exposure between cases and controls. How many are exposed in case and how many are exposed in controls? So it is going in a backward direction. So the study is retrospective study. If they ask case control study is prospective, no, it is retrospective study. Since you are taking two groups and you are comparing the exposure pattern, one side we have case, the other side we have controls. One side we are having case, the other side we are having controls. We are comparing the exposure pattern between cases and controls. It will be easy to conduct for us. It will not take much time. You are not doing any follow-up, which is taking less time, which is very quick to conduct. If they mention words like this, which is very quicker to conduct, which is taking less time, then the answer is case control study. Less expensive because it is quicker. The study will happen very fast. It won't take much time. So it is inexpensive study, less expensive study. Requires less number of subjects because there is no loss to follow. Cohort study needs more individuals because dropouts can happen. That is why case control is very quick to conduct. Inexpensive study, fewer subjects are required. Multiple exposures can be assessed. Yes. Take lung cancer. You assess so many risk factors for that. Occupation, smoking, asbestos, sex, age. You can assess the influence of multiple risk factors because you are asking history. The study is retrospective study, so it is giving one chance for you to assess the influence of multiple risk factors also. Keep this in mind. Important question. Rare disease. Don't do cohort study, I am telling. Rare disease follow should not be done. It will take time and the disease is rare outcome or rare disease. Cohort should not be done. Which is the preferred study design for a rare disease association if they ask? Case control study. Yes, case control study. Recall bias will be seen because already having disease will make them recall more. You are asking one simple question, are you a smoker? Are you a smoker? Both sides. But who will try to recall the exposure better? because deceased individuals will think more. I'm telling. Cases will try to recall the exposure better because they are suffering from that disease. That will make them to think more. Recall bias will always overestimate the association. Very difficult to eliminate recall bias. The only way of doing like eliminating recall bias is change the study design. This will be in the option. The systematic error which is seen in case control study. See the words properly. The systematic error which is seen in case control study can be eliminated by doing prospective study. Means the bias which is seen in case control study which is eliminated by doing cohort study, where you start from exposure, go towards outcome. You're changing the study direction itself. What is the answer? Recall bias. Good. Odds ratio we estimate. What is the formula? AD by BC. AD by BC. So these are the points in case control study. Now come to cohort study. Yes. Now come to cohort study. So the importance of cohort is there is this cause to effect relationship. We start from exposure, we go towards outcome. So keep this in mind. We always start from exposure, go towards outcome. That means there is temporal association. Most important criteria to prove etiology, temporal association. Initially, I have discussed this word in the discussion part. Since you are doing follow-up in a forward direction, you calculate new cases between exposed and non-exposed group. How many new cases in exposed group versus how many new cases in non-exposed group. The study can be done either in a prospective way or retrospective way. Keep this in mind. Prospective study will take some time. It is time-consuming study. Concurrent cohort study, you have to stay with the groups, exposed, non-exposed. You have to do follow-up. You have to do follow-up. Outcome in exposed group, outcome in non-exposed group. It will take some time. Retrospective cohort study using existing records. Retrospective cohort study using existing records. You can save time and cost. Cohort studies can be done either in a prospective way or a retrospective way. Needs more number of subjects because there is loss to follow up always. Attrition means dropouts. Since you are doing study in a forward direction, dropouts will happen usually. That word dropouts is also known as attrition. Attrition bias is seen in cohort study. Not suitable for rare disease because it will take time. You're not sure whether the disease will happen or not. 10-15 साल like 10-15 years के बाद like something should happen. If it does not happen, then you'll be like thinking what the study I did, whether it is proper or not. No. Cohort study should not have been done. You should have done what study? Rare disease case control study. Good. Multiple outcomes can be studied. Yes, because you are going in a forward direction. Starting from exposure, you can study multiple outcomes of smoking or multiple outcomes of alcohol. What we calculate is very, very important. In a cohort study, usually we calculate three things: risk ratio, attributable risk, population attributable risk. Repeat with me. Risk ratio, good. Attributable risk and population attributable risk. So what is the formula for risk ratio? Incidence in exposed by incidence in non-exposed. You are dividing two things. Incidence in exposed divided by incidence in non-exposed. Attributable risk means what is the formula? Incidence in exposed minus non-exposed divided by incidence in exposed. But population attributable risk is not just for the exposed group, it is for the whole population. How much advantage you can give for the whole population if risk factor is eliminated. That is why this is the most important thing. Out of wrapping RAP, which is most important for public health, population attributable risk. Come to this table, very important. How to summarize the properties of a test. How to summarize the properties of a test? They'll be asking what is sensitivity. They'll be asking what is specificity, what is positive predictive value, and what is negative predictive value. Just look at the table once. I'll give 1 minute for you to read on your own. Just look at the table once, then you'll get some idea, so that when I discuss it becomes easy for you. Just look at the table once. Yes, good. Patients with bowel cancer already having disease. Patients with bowel cancer already having disease. That is the reality. That is the reality. How much your test will detect? How much your test will detect? That is what you are showing. Ability of a test to detect true positives. Ability of a test to detect true positives. What is that called as? Sensitivity of a test. Sensitivity of a test. See here, out of 30, how many are detected by your test? You are putting one test, that is fecal occult screening test. Total 30 are there with disease. In that, how many are detected by your test? 20. So 20 by 30, that is sensitivity of your test. 20 by 30, that is sensitivity. So 2 by 3, 66%. What is sensitivity of a test? Repeat the words. Ability of a test to detect true positives. If this much is detected, remaining percentage will not be detected. Not able to detect, that is false negatives. If sensitivity is 67%, false negatives will be remaining 33%. They'll mention this question. If sensitivity is increasing, if it becomes 80, false negatives will become 20%. Percentage I'm telling. If sensitivity is increasing to 90%, if there is one more test with sensitivity of 90%, false negative results will become 10%. So if sensitivity is increasing, false negatives of a test will decrease. False negatives of a test will decrease. So high sensitive test, less false negative results. A high sensitive test, less false negative results. So keep this in mind. High sensitive test, less false negative result. Now come to specificity. Now come to specificity. Read the table. Good. What is specificity of a test? Specificity of a test is ability of a test to detect true negatives. Ability of a test to detect true negatives. So out of total normal healthy individuals, how many are detected as normal? That is true negatives. Out of total healthy individuals, how many are detected as normal? That is true negatives. So out of this much, the percentage true negatives is 91%. The percentage true negatives is 91%. If 91% true negatives will be there, if 91% true negatives will be there, remaining 9% will be false positive results. Remaining 9% will be false positive result. So if specificity is more, false positives will be less. If specificity is increasing, false positives will decrease. False positives will decrease. So high specific test will have less false positive result. This is the first discussion initially. So repeat, sensitivity and false negatives will be opposite. Specificity and false positive results will be opposite to each other. Then comes how to calculate positive predictive value and negative predictive value. Positive predictive value and negative predictive values will indicate diagnostic power of a test. Will indicate diagnostic power of a test. So always keep this word, diagnostic power of a test. One is for inclusion, the other is for exclusion. One is for inclusion, the other is for exclusion. Out of total test positives, like 20 plus 180, 200. Out of total test positives, how many are having disease? Very less. Out of total test positives, how many are having disease? That is positive predictive value of a test. In this test, positive predictive value is very, very, very less. 10% means it is very less. Remember this point. Out of total test positives, how many are having disease? That is positive predictive value. In the same way, out of total test negatives, 1830, how many are normal? This is negative predictive value. Out of total test negatives, how many are true negatives? So it is very, very high. So using this test as a diagnostic test, I am telling, example, when you are using it for diagnosis, we have to comment on predictive values. We have to comment on predictive values. Which is better for this test? You tell. Very good. Positive predictive value or negative predictive value? Negative predictive value. That means diagnostic power of inclusion or diagnostic power of exclusion. If I use this word, diagnostic power of inclusion or diagnostic power of exclusion? Exclusion, ruling out. If you are tested negative, you are almost ruled out. 99.5% negative predictive value. But if you are tested positive, chance of having disease is very, very, very less. Positive predictive value is just 10%. If this is the question, calculate PPV or calculate NPV. So when the table is given, when you come like this, you get sensitivity. When you come like this, you get specificity. So when you drag the things vertically, you get sensitivity and specificity. When you catch the same things and if you go horizontally, you get positive predictive value and negative predictive value. So how to calculate these four things? Now see this very important thing. Skewness is very important. The data is skewed, means there is something abnormal in the data. As you can see in the image, the data is skewed means there is something abnormal in the data. If everything is fine, there is a bell-shaped curve. If there is a bell-shaped curve, there is no outliers in the data. Remember the words properly. In case there is outlier in the higher end, for example, I am telling, if this is the data given to you, 1, 2, 3, 4, 10, 99. See this number 99. 99 is an extreme value, which is towards the right side, which is towards the higher end, 99. Because of this 99, which is outlier in the higher end, what will happen to mean compared to median? I'm telling, mode can be present, cannot be present. If mode is there in the data, fine. But if mean is more than median, it will become right skewed data, outlier in the higher end. Always mean is affected by outliers. Keep this in mind. When you calculate average, it will become very high compared to median. Right skewed data is also called as positively skewed data. Positively skewed data, mean will become more than median. But if the scenario is opposite like this, if the total scenario, what I'm telling is completely opposite like this, so you are seeing like this. For example, I'm telling 96, 96, 94, 93, 91, 92, 2, 3. If I'm telling like this, 2, 3. This is the question. Now tell me, outlier is in the higher end or lower end? Answer my question. Outlier is in the higher end or lower end? Lower end. 2, 3. Outlier is in the lower end. If this is the question, if outlier is in the lower end of the data, mean will become less than median. Mean will become less than median. If mean is less than median, it will be left skewed data or negatively skewed data. Outlier in the higher end, right skewed data. Outlier in the lower end, left skewed data or negatively skewed data. So always keep in mind the tail of the curve is mean. If the tail is towards the right side or if the tail is towards the left side, that tailing will happen because of outliers only. Outliers means extreme values. Higher end right skewness, lower end left skewness. Mean is affected. So always if the question comes, which is the preferred measure of central tendency? See the words properly. Which is the preferred measure of central tendency for skewed data? What is the answer? Median. Don't use mean. Mean is getting affected. Mean is getting affected. So always we have to use median for skewed data. See this sampling. Very important table. What I am showing here. It's very easy to remember also. Sampling. Means there is a population like this. You have to take one small sample out of that. From the population we are taking sample. This is sampling for the study purpose. Simple random sampling. Simple random sampling. What you are doing, you are selecting individuals randomly. All are having equal chance. You cannot predict anything. Lottery method. Lottery method. Out of 100 students, 10 students are selected randomly. But systematic random sampling means, again you have to go back to your class notes. This is just a rapid revision session what we are doing. What is happening in systematic random sampling is, we are giving one unit every third or every second, like that numbers will come. Here it is every, start with a second number, then select every third unit, like that. What is there? Start with second individual and select every third. If the word comes like every third, every fourth and all, you have to mark the answer as systematic random sampling. You have to mark the answer as systematic random sampling. Stratified random sampling means what they are doing, as you can see there, we are dividing them into two groups, subgroups. For example, males and females you separate. Then accordingly we have to select. You have to give proper representation. You have to give proper representation. As you can see there, there are 6 males, 9 females, for example. 6 males and 9 females. In that, from 6 you are selecting 2. From 9 you are selecting 3. You are giving proper representation. Stratified random sampling is used for non-homogeneous populations, when the number in the group will be different. This side we have 6, this side we have 9. But I have to give proper representation according to their size, according to the population size. If they make this question, within 6 you are selecting 2, within 9 you are selecting 3. This is stratified random sampling. Proper representation for selected subgroups. It is preferred for non-homogeneous population. Cluster means group. You can see here, you are selecting groups. You are making different clusters now. Cluster 1, cluster 2, cluster 3, 4 and cluster 5. In that, 2 clusters are selected randomly. C2, C4 will come. Cluster sampling means random sampling for clusters, not for individuals. Baki sub sampling mein the sampling unit will be individuals, but here it is not individuals. Remember, it is for the cluster. That is what they want to show. So now tell me, lottery method, simple random sampling. Every third, every fifth, like that. If word comes, it is systematic random sampling. 2 separate groups, proper representation, stratified random sampling. Selecting clusters, groups, that is cluster random sampling. Now this table is repeatedly asked in the exam, that is what you are doing here, like what test is applied in what situation. This is my question. What test is applied in what situation? Test of significance. First thing is student t-test, also called as unpaired t-test. When you are comparing mean values between two groups, see the words properly, mean values between two groups, that is student t-test is used to check the significance. What will happen? One group you are giving treatment, the other group you are giving placebo, that is RCT what you are doing. Later you will be comparing the mean values, mean hemoglobin levels, for example, you are comparing whether the difference is statistically significant or not between two groups mean value. See the words properly. Mean two groups. What test is used? Student t-test, also called as unpaired t-test. Student t-test is also called as unpaired t-test. Now come to this. One group if you are taking before intervention, after intervention, mean values you are comparing. For example, mean weight of the group is 80 kg. After intervention, it is decreasing to 60 kg. One group mean values, that is before intervention, after intervention we are comparing, it is paired t-test. Paired t-test is for one group before after intervention. See the words properly. One group before after intervention, it is paired t-test. Means one group you are taking. Unpair means दो अलग अलग group है. Paired means एक ही group है. What my point? Good. More than two groups mean if you are comparing, we use ANOVA test. We use analysis of variance. So tell me three tests used for mean. Very good. Tell me the mnemonic. Student t-test, paired t-test, ANOVA test, SPA. Remember the mnemonic. Mean. These tests which are used to compare mean values are known as parametric test. Parametric test will be used to compare mean values. Yes, sir. Now come to the test which can be used to compare proportions. Chi-square test for two or more than two groups. For example, you are comparing cure rates between two groups. 80%, 60%. Group 1 80%, group 2 60%. Comparing cure rates between two groups. Which group is giving better cure rate? Treatment is making a difference or not? Proportions, two or more than two groups. Chi-square test. One group if you take. This is the question in the exam repeatedly. See the words McNamara test. 80% are obese in the group. After lifestyle modification, 20% are obese. Means same group you are taking and doing this. Before, after intervention, proportion. What test? McNamara test. Tell me two tests for proportions. Chi-square test, McNamara test. The mnemonic is Chief Minister. Chief Minister. Remember this. Good. Association. When you are making a table, 2 by 2 table, when you are doing a study like case control study, they'll frame this question. Odds ratio will indicate strength of association. Yes. Odds ratio will indicate strength of association, but what test will be used to detect significance of association? What is your answer? What test is used to detect significance of association? Chi-square test of association. Chi-square test of association will be the test used to check the significance of association. Odds ratio will indicate strength of association, but chi-square test will indicate significance of association. Remember the words. Parametric test, what is the mnemonic? SPA. Student t-test, paired t-test, ANOVA test. Non-parametric test, there are so many tests. Two things are used to compare proportions. What is the mnemonic? Chi-square test, McNamara test for proportions. Remaining three things for median. जो बाकी tests है ना, this is to compare median values. I told median is used for skewed data representation. Baki three tests for median. So two things for proportions. Next test for median. Non-parametric test, total 5, remember. They'll give the tell me the names of non-parametric tests. Like that they will ask the question. Few more things in stats. What you should know is formula for coefficient of variation. Standard deviation by mean into 100. Always we take the relationship between two things. Standard deviation is 3, mean is 6. See the words properly. Standard deviation is 3, mean is 6. When you take the relationship 3 by 6, that is 1 by 2, half, 50% variation in the data. Just I want to know between two groups which will show more variation. You can use coefficient of variation to compare variation of two variables in two different units. That can also be done like pulse and BP. which will show more variation, whether pulse will show more variation or BP. The main formula you should know is standard deviation by mean into 100, percentage variation in that variable or percentage variation in that group when you are comparing with one more group. If I want to compare relationship between two variables, like for example height and weight, how they relate to each other, positive correlation. Or if I want to know income and infant mortality rate, how they relate to each other, negative correlation. Height, weight, positive correlation. Infant mortality rate and income. If income is increasing, IMR will decrease, negative correlation. Scatter diagram is used to represent correlation. This is the question. Scatter diagram is used to represent correlation. So there are two types of correlation, positive and negative. If there is no correlation, for example, height of individuals and pulse, they don't show any correlation. So in the words properly, height and pulse, they don't show any correlation. That means the image will be like this. There won't be linearity, there won't be any landing, it is no correlation. So the question is, they'll mention the graphs for you and they will ask, arrange it in sequence. This is perfect linear positive correlation. This is perfect linear negative correlation. Correlation coefficient is very important. It ranges from 0 to +1, 0 to -1. For this graph it is +1. For this graph it is -1. Remaining all the things, they range from 0 to +1. They will range from 0 to -1. So what is used to indicate the correlation? Scatter diagram. What is indicating the strength of correlation? Correlation coefficient. How it is represented? R. What is +1? Perfect linear positive correlation. What is -1? Perfect linear negative correlation. Remaining graphs, these three things range from 0 to +1. These three things range from 0 to -1. This graph is showing no correlation. So correlation coefficient will be 0. Correlation coefficient will be 0. So the thing what we have discussed as of now is part 1 of your FMG topics which are important for your exams. We are discussing everything in rapid revision mode. So let us take a break of 15 minutes. Then we can discuss part 2. So we can take a break of 15 minutes and we can discuss part 2 of this. So the next thing is we were discussing some important questions on program communicable diseases and other topics left in the part 2 session. So tuberculosis, National TB Elimination Program, National TB Elimination Program. So the diagnostic purpose as of now, we are using directly CBNet for all the patients. So what is the diagnostic test of choice? CBNet. And if the patient is positive for TB, patient is positive for tuberculosis, we'll be using 6 months of treatment. So drug sensitive tuberculosis, 6 months of treatment, 2 months of intensive phase and 4 months of continuation phase. 2 months of intensive phase and 4 months of continuation phase. So 4 drugs in intensive phase, HRZD, and 3 drugs in continuation phase, HRE. Thiambutal is used in continuation phase. So what will happen? These will come in the form of tablets. Fixed dose combination is used. The number of tablets per day. The number of tablets per day is based on body weight of the patient. Number of tablets per day is based on body weight of the patient. So this is how you manage drug sensitive TB. Total 6 months of treatment, 2 months of intensive phase and 4 months of continuation phase. HIV tuberculosis, very important because the most common opportunistic infection. In HIV cases, tuberculosis. So TB will be the cause of death also. If they ask, the most common cause of death in HIV is tuberculosis. So what you are supposed to do? Diagnose TB using CBNAT. So CBNAT is the test of choice for diagnosing tuberculosis in HIV patients also. So once the patient is positive for TB and HIV, if they are diagnosed together, start ETT and add ERT after a gap of 2 weeks. First, we have to treat opportunistic infection. Then we have to add ERT. So the gap will be 2 weeks. If at all there is TB meningitis and HIV together, if there is TB meningitis and HIV together, then the gap should be 4 weeks. Normal TB and HIV, if they ask, gap is 2 weeks. But if there is TB meningitis and HIV, then the gap should be 4 weeks. Tuberculosis, always remember, when the patient is coming to the hospital, that is passive case finding, but you are asking health workers to go into the community. You are asking health workers to go into the system and detect the cases of tuberculosis. So you will be going to slums, tribal areas, in those areas where there is overcrowding. In those areas where there is overcrowding, slums, tribal areas, if you are going there and detecting the cases, it is active search of cases. So there are two things, passive case finding and active case finding. Active search in overcrowded areas. What is NICSHI? NICSHI is a website. Kshay Roga means tuberculosis. Na? So NICSHI is a website to detect TB, means to notify TB. Already you have detected, to notify TB cases. Don't make this mistake. It is not detection. There is a question, it will detect TB. It's a test of choice. No, it is not test. It's a website for online notification. Online notification to district tuberculosis officer. Yes, you'll be notifying to whom? DTOs, district tuberculosis officer. Monthly notification. So what is the frequency of notification? It is monthly notification. TB case notification is mandate. Mandate means it is under IPC section. IPC section 269, 270 will take care of this. If you don't notify case of TB, you are giving chance for a communicable disease to spread. This is what they want to say. You are giving chance for a communicable disease to spread. That is why it comes under IPC section 269, 270. For notification, the doctors will get 1000 rupees per patient. 500, 500 we divide like this. 500 on notification, 500 for outcome declaration. At a time you cannot give 1000 rupees. 500 on notification, 500 for outcome declaration. Patient will get 500 per month during treatment. This is NICSHI Poshan Yojana. NICSHI Poshan Yojana, it is for the patients. They'll be getting 500 per month during treatment. So how many months of treatment? 6 months of treatment. So the patient will be getting 500 per month during treatment. So what is the advantage of NICSHI Poshan Yojana? For nutritional purpose, to promote nutrition of the patient. 99 dots means what they do. They'll be keeping hidden numbers beneath the blister packs. You're giving treatment packs, you're keeping hidden numbers beneath that. So the patient is giving missed call to that number. Once you open the tablet, there is one strip with number. The patient, these are random numbers what you're keeping. So the patient is giving missed call to that number. When the patient is giving missed call to that number, the call is identified by the software. The patient is taking treatment. You are monitoring adherence to the treatment. This is the question. To monitor adherence to the treatment, what initiative is there? It is 99 dots. 99 dots. Janani Suraksha Yojana. So remember the table. Janani Suraksha Yojana. What is the use of this scheme? To reduce maternal mortality. The pregnant should come to hospital and deliver. That is what their purpose is. The pregnant should come to hospital and deliver. So there are two types of states. Based on the number of hospital deliveries, there are two types of states. Low performing states and high performing states. Low performing state delivery rate is very less. High performing state delivery rate is good. Low performing state total 10. How to remember? UP, Uttarakhand, before they were together, now it is separate. MP, Chhattisgarh, yes. Bihar, Jharkhand. Remember like this, total 6. UP, Uttarakhand, MP, Chhattisgarh, Bihar, Jharkhand, total 6. Before they were together, now it is separate. Rajasthan, Odisha, Jammu, Assam. Roja is the mnemonic. Rajasthan, Odisha, Jammu, Assam. Roja is the mnemonic. Total 10 low performing states. All the pregnants in low performing states will get incentives. But high performing state, either they have to be below poverty line or SC/ST pregnants. They have to be below poverty line or SC/ST pregnants for high performing states. This is irrespective of age and parity. So always remember this word. This is irrespective of age and parity. Two things are very important. Cash is given up to 2 live births only. No, it is irrespective of age and parity. This is the newer thing. And institutional delivery, depending on the state, how much mother will get, Asha will get. Why Asha workers? Because they are coordinating the services. So Asha worker will be the coordinator. They will be bringing the pregnant to the hospital and again they are taking her back. Now, for this purpose, Asha will be given incentives. Asha workers will be given incentives. Rural area, we keep more incentives comparatively. So rural areas, the incentives will be more comparatively. See here, Mother Asha, Mother Asha. How much Asha worker will get in rural area? 600 rupees. Urban area, 400 rupees. Mother in rural area, LPS highest 1400 rupees. Last time question, Madhya Pradesh, rural area, how much mother will get? Home delivery, they are giving 500 rupees now for below poverty line pregnants. Home delivery, 500 rupees for below poverty line pregnants. Home delivery, there is nothing for Asha worker. Only pregnants will get, but they have to show BPL certificate below poverty line. Janani Suraksha Yojana will give cash incentives, but the other schemes related to mother care you should know. JSSK, don't confuse, it is Janani Shishu Suraksha Karyakram, where the free services are given for pregnant and sick infants. It is not sick neonate, it is sick infant. Till 1 year we are giving the services. Usually when we discuss in the classes, the mnemonic what I say is DTC, Delhi Transport Corporation. D for diet, drugs and diagnostics. Transport facility, home to hospital, again drop back, or hospital to hospital. We are referring the patient, like we are referring the pregnant, or we are referring the sick infant from one hospital to another hospital. The transport is free. Caesarean section, nothing to charge for caesarean, and blood also. So all these are important components where you are not charging anything. JSY is giving cash, JSSK is giving free services. This will complement JSY, because when you are giving free services, it becomes easy for the beneficiaries. They will come to hospital, they will deliver. When the infant is sick, they will come and they will get the treatment. We can reduce mortality rates. Pradhan Mantri Surakshit Matritva Abhiyan. This scheme is very important. Antenatal clinics are there. Pradhan Mantri Surakshit Matritva Abhiyan, PMSM clinics will be there. These are antenatal clinics. on 9th of every month, where you will be identifying the danger signs the pregnant is coming. Usually in the second or third trimester, they will come in the clinic. One visit is given. Out of total 4 minimum antenatal visits, one visit they have to visit and come and get themselves checked at least once in the clinic. Stickers will be given indicating the condition. Green, no risk factor. Red, high risk pregnancy. Blue sticker is separately given for pregnancy induced hypertension. Yellow sticker for 3 things: gestational diabetes, hypothyroidism, pelvic inflammatory diseases. Repeat: gestational diabetes, hypothyroidism, pelvic inflammatory diseases. Pelvic inflammatory diseases. So, what are the stickers under PMSMA scheme? Pradhan Mantri Surakshit Matritva Abhiyan clinics: green, red, blue, yellow. Don't confuse between two schemes. Lakshya scheme is for labor room quality. You have to improve the labor room infrastructure. It is more about labor room quality. And Dakshata scheme is for training doctors and nurses, where you train them for delivery practices, intrapartum care and immediate postpartum care. Just after delivery, chances of hemorrhage, PPH, is very high. Postpartum hemorrhage. So in such situation, how to reduce mortality? How to reduce mortality? So if the question comes L for Lakshya, L for labor room quality, D for Dakshata, D for delivery practices. D for Dakshata, D for delivery practices. Suman scheme. See the full form now. Surakshit Matritva Ashvasan means we have to guarantee the services what you have planned for. That service has to reach the pregnant and child. Service guarantee charter has to be displayed in the hospital notice board. These are the services what are you supposed to get, that is displayed in the hospital. And grievance redressal mechanisms is there. If you are not giving that service, if the pregnant is already knowing that I have to get this, if you go to a hotel, they will display the menu, idli vada sambar and all. If it is not given, they will have the right, because you are creating the awareness before only. You have to get this. Service guarantee charter is displayed. If not given, complaints, grievance redressal mechanisms are there, and zero tolerance policy is maintained. If this is the question, zero tolerance policy is for Suman scheme. Means they are making sure that you are giving service guarantee charters, you are keeping one complaint raising mechanisms, so that whatever the services you are planning is reaching the beneficiary, Suman scheme. The previous part I have discussed how to reduce maternal mortalities, like for example, Janani Suraksha Yojana, Janani Shishu Suraksha Karyakram, where infant will also come. Pradhan Mantri Surakshit Matritva Abhiyan, PMSMA clinics detect danger signs. Lakshya, labor room quality. Dakshata for delivery practices, it is training program for doctors and nurses. Suman is Ashvasan, guarantee. You are making sure that the service will reach the beneficiary. Child health related schemes, HBNC, home based newborn care. What is home based newborn care is Asha worker will be trained how to visit, like what are the things you need to take care of, especially for neonatal care I am telling. So home visits by Asha worker, total number of visits you see there. Yes, how many visits in case of home delivery? 7 visits. 7 visits. Day 1 is day of delivery. Day 1 is day of delivery. Then it is like this: 1, 3, 7, 14, 21, 28 and 42. 14, 21, 28 and 42. So total how many visits? 7 visits. Total how many visits? 7 visits. Then comes hospital delivery, it is 6 visits. Hospital delivery cesarean section, it is 5 visits. Cesarean section, it is 5 visits. So it is always in descending order: 7, 6, 5. Incentive for Asha worker is 750 per child. Incentive for Asha worker is 750 per child. Remember the incentives given. 750 per child. Don't make mistake in this. It is 750 per child. What my point? Then home-based care of young child. This is totally different. Home-based care of young child is totally different from home-based newborn care. So what is the main thing? Here the Asha worker will train or counsel the pregnant or the newborn related mother for nutritional purpose. Total 5 visits are there. Total 5 visits are there starting from third month. Then every 3 months once. 3, 6, 9, 12 and 15th month. 3, 6, 9, 12, 15th month. Here also Asha worker is given incentives 250 per child. Again remember this, it is 250 per child. Again for Asha worker incentives. Highlight this word. Incentives for Asha workers. So now come to facility based newborn care. FBNC, facility based newborn care is what are the services we are supposed to give in the hospitals? What are the services we are supposed to give in the hospitals? SNCU, special newborn care units. It is at district hospitals. Special newborn care unit is at district hospitals. Newborn stabilization units. Newborn stabilization units is at CHC level. Community health center or first referral units. Community health centers or first referral units. In the labor rooms, when you go and check, it is always newborn care corners. Newborn care corner. So newborn care corner will be one bedded session. So now match the following: special newborn care units, district hospitals; newborn stabilization units, CHCs; newborn care corners, labor rooms. Newborn care corners in the labor rooms. What is the target of Indian Newborn Action Plan? What is the target of Indian Newborn Action Plan? Single digit mortality rates we have to achieve. Single digit neonatal mortality rate and stillbirth rate by the year 2030. Remember the time limit also. Single digit neonatal mortality rate and stillbirth rate by the year 2030. India has to achieve this target by which year? If they ask, it is by 2030. What is the target? Single digit. Now the recent neonatal mortality rate is 20. It has to come down to single digit by the year 2030. What is very important for child health is Rashtriya Bal Swasthya Karyakram, where you will be doing screening in the age group of 0 to 18 years. Screening in the age group of 0 to 18 years. You will be screening for defects, deficiencies, diseases and developmental delays. So see the words properly: defects, deficiencies, diseases and developmental delays. Especially when they ask the word deficiencies, it is more of nutritional deficiencies what will be screening. See the words properly: nutritional deficiencies like vitamin A, anemia, vitamin D, goiter, severe acute malnutrition. Vitamin A, anemia, vitamin D, goiter, severe acute malnutrition. In the exam, if they ask question, zinc deficiency is screened? No. So what is screening and early intervention? If I frame questions like this, screening and early intervention, if this is the word, exact word given in the exam, screening and early intervention, what is your answer? Rashtriya Bal Swasthya Karyakram. Don't make mistake in this. The answer is RBSK, Rashtriya Bal Swasthya Karyakram. So how many days are screened for? 4 days. So these are all the schemes which are important for newborn and child health. Newborn and child health. Malaria drug policy, very important question in the exam. Without malaria treatment, you cannot go to the exams. Treatment part. Falciparum, ACT is given. ACT for how many days? 3 days. Primaquine, 1 dose. Yes, don't make mistake, it is not 14 days. Falciparum, we are giving primaquine 1 dose because it will help in preventing the recrudescence. When the parasite is in the blood gametocide form, it will recur, that is recrudescence. Falciparum will show recrudescence. So use primaquine 1 dose. ACT for 3 days. Artemisinin combination therapy is ACT. It is not same for all the states. Northeast states we are using artemether lumefantrine. Other states we are using sulfadoxine pyrimethamine. Remember this word. For Northeast states we are using artemether lumefantrine. For other states we are using sulfadoxine pyrimethamine. So the words properly. Sulfadoxine pyrimethamine. So the second drug is very important. The second drug is long-acting antimalarial. Always the second drug used is long-acting antimalarial. What is the treatment for Vivax? Chloroquine for 3 days, primaquine for 14 days. Chloroquine for 3 days, primaquine for 14 days. Mixed infection, if it is mixed, you have to mix the treatment also. ACT for 3 days and primaquine for 14 days. What is the use of primaquine 14 days? To reduce relapse. To reduce relapse. Oval treatment is same as Vivax. Plasmodium malaria treatment is same as Falciparum because they both show same, like oval will show relapse also. Plasmodium malaria will show recrudescence also. That is why we managed oval cases as Vivax and Plasmodium malaria cases as Falciparum. Like that we give the same treatment part, I'm telling. Pregnancy, very important, malaria. Falciparum, first trimester we have to use quinine because ACT is contraindicated. Keep this in mind. ACT is contraindicated. So we have to use quinine. Other trimesters we can use ACT. Second and third trimester we can use ACT. Vivax treatment, it is just chloroquine. And P for pregnancy, P for primaquine. Primaquine is contraindicated in pregnancy. Don't use primaquine in pregnancy. And chemoprophylaxis depends on the duration of stay. When you are going and staying in an endemic area, depending on the duration of stay, we are using chemoprophylaxis up to 6 weeks. You can, if your stay is up to 6 weeks, you can use doxycycline. If your stay is for more than 6 weeks, we have to use mefloquine. Mefloquine because it is long-acting antimalarial. If you are going and staying there for more than 6 weeks, we have to use mefloquine. Got my point? We are using mefloquine. So what are the two drugs used? D, M. In case if there is any contraindication, use chloroquine. C, DMC for chemoprophylaxis, Delhi Medical Council. Doxy, mefloquine, chloroquine, Delhi Medical Council. Mefloquine contraindications, important. Cardiac conditions, convulsions. If I frame a question like this, convulsions, businessman going and staying for around 2 months in an endemic area, mefloquine cannot be used. What is the replacement drug for chemoprophylaxis? Answer is chloroquine. So tell me 3 drugs. Repeat with me. DMC, Delhi Medical Council, Delhi Medical Council. Kala Azar, how the patient will present with symptoms? That is what I wanted to ask. Kala Azar will affect viscera, visceral leishmaniasis. Means you are usually having liver spleen involvement. The patient is having fever, anemia, hepatosplenomegaly. Repeat my words. Fever, anemia, hepatosplenomegaly. Patient is not responding to treatment. When you are starting malaria treatment, the patient is not showing any response to malaria treatment. So the question was very simple. Fever, anemia, hepatosplenomegaly. Fever, anemia, hepatosplenomegaly, not responding to antimalarials. This is the question what I am asking. Not responding to antimalarials. What disease we need to rule out? What is your answer? Yes, we need to rule out Kala Azar. We need to rule out Kala Azar. So what is the diagnostic test of choice? No need to go for bone marrow biopsy, splenic aspirates. Those are invasive things. Just there is one rapid diagnostic kit. RK39 we have now. RK39, it is antibody detection kit against K39 antigen. K39 is an antigen, it's an epitope on hemastigote of leishmania. So what you are supposed to do is K39, it's an epitope on hemastigotes. If you are detecting antibodies against K39, you're detecting antibodies against K39, that means the patient is infected. So it is antibody detection kit. Most of the kits what you'll be using is detecting antigen, but this is antibody detection kit. What my point? Antibody detection kit. RK39, if it is positive, start treatment. No need for any confirmation, you have to start treatment. What is the drug of choice for Kala Azar? Liposomal amphotericin B, LAM, what we say, single dose infusion. This is the drug of choice. Miltefosine is not the drug of choice. Miltefosine is given orally. Miltefosine is not the drug of choice. Replacement drug is miltefosine. But miltefosine is a drug of choice for PKDL. What is PKDL? Post Kala Azar dermal leishmaniasis. Very good. Miltefosine is a drug of choice for PKDL, post Kala Azar dermal leishmaniasis, but not for visceral leishmaniasis. Visceral leishmaniasis, the drug of choice is always liposomal amphotericin B. The replacement drug is miltefosine. Active case finding we have to do. Go to Kala Azar endemic areas. Search for 2 weeks. Whatever the cases we get, we need to detect. That is Kala Azar fortnight. Kala Azar fortnight. So what is fortnight? Search for how many weeks? 2 weeks. And this is done once in 3 months. Not once in 6 months. It is done once in 3 months. That is what is called as quarterly search of cases. Quarterly search of cases is done for which disease? Kala Azar. What is that called as? Kala Azar fortnight. Kala Azar fortnight. Indoor residual spray is for sandfly. Sandfly, the insecticide used as synthetic pyrethroids. S for sandfly, S for synthetic pyrethroids. Sandfly has shown some resistance to DDT. What is the scientific name of sandfly? Phlebotomus argentipes. Phlebotomus argentipes. It has shown some resistance for DDT now. That is why within the cattle sheds, I am telling, you are going to rural areas, cattle sheds, where you'll be seeing the crevices and holes. There will be doing some sprays. That is indoor residual spray. What is the insecticide used? Synthetic pyrethroids. These are the questions on Kala Azar. How to eliminate Kala Azar? HIV treatment, very, very important. First and foremost, if the patient is having antigen HIV positivity, start treatment as early as possible. The policy is called as test and treat policy. As soon as diagnosed, irrespective of CD4 count, irrespective of clinical staging, we have to start treatment. Now the combination used is TLD. What is TLD? Tenofovir, lamivudine, dolutegravir combination. Before we used to have TLE combination. Now we are using TLD combination. Lifelong treatment, 1 tablet fixed dose combination is used. Now come to PPTCT, mother to child transmission. Pregnant will get TLD now. Any trimester, any gestation, don't worry, start TLD. Before TLE was used, efavirenz combination, now we are using TLD only. Newborn prophylaxis is very, very, very important. Listen. If the mother is on ERT, everything is fine, use nevirapine for newborn. That is sufficient, 1 drug. Minimum duration 6 weeks, maximum duration 18 months. Minimum duration 6 weeks, maximum duration 18 months. In case if the mother is not on ERT, mother is not taking, she does not know that she is HIV positive. She came to the clinic. Now she has been diagnosed to be HIV positive. High risk infant, yes, correct. The newborn will get 2 drugs, dual drug prophylaxis. This is what is called as DDP, dual drug prophylaxis. In case of artificial feeding or exclusive replacement feeding, prophylaxis for 6 weeks. If the mother is breastfeeding, prophylaxis for 12 weeks. Repeat. If it is artificial feeding, or we say exclusively replacement feeding, she is using artificial milk, 6 weeks, 2 drugs. If at all breastfeeding is being done, 12 weeks, 2 drugs. Not on ERT, 2 drugs should be used. On ERT, 1 drug, not on ERT, 2 drugs. Cotrimoxazole prophylaxis to prevent pneumonia, starting from 6 weeks till 18th month, because early infant diagnosis can be done at 6 weeks. Early infant diagnosis can be done at 6 weeks. 6 weeks. Now the diagnostic test of choice for early infant diagnosis is total nucleic acid PCR, TNA PCR. What is TNA if they ask? Total nucleic acid PCR. Don't make mistake, it is TNA PCR. Before DNA was used, RNA was used. Now we are using total, both the components, TNA PCR at 6 weeks. Confirmatory testing is done at 18th month. Confirmatory testing is done at 18th month using antibody testing. So now tell me, repeat my words. Yes, correct. Early infant diagnosis is done at 6 weeks using total nucleic acid PCR. Post-exposure prophylaxis. After exposure to HIV body fluids, you have to take TLD for 4 weeks. Started within 72 hours. That is the upper limit. After that, no use. And what the question is, TLD for 4 weeks. This is what we follow in India. But in case if they ask, what is the best regimen? Yes, tell me. What is the best regimen? TED combination. Tenofovir, emtricitabine and dolutegravir. This is the best combination as per WHO. See the words in the exam. Depending on the words you have to answer. What my point? Good. In India we follow TLD, but as per WHO, which is the best combination if they ask, it is TED combination. Tenofovir, emtricitabine. You make mistake here. Highlight this word. Emtricitabine and dolutegravir. AFP surveillance. What is AFP? Acute flaccid paralysis. AFP surveillance. To rule out which disease? Polio. So what we do? To rule out polio, we do one procedure. That procedure is called as AFP surveillance. Acute flaccid paralysis surveillance. First and foremost, collect the stool samples. You have to isolate virus. We have to give confirmatory diagnosis. Collect the stool samples. How many samples are collected? 2 samples, 24 hours apart. Today, tomorrow. Each sample should weigh 8 grams. This is the first thing. Ideally within 2 weeks. Maximum limit is there. 60 days. After that, no use of sample collection. Got my point? After that, no use of sample collection. So everything is 2, 2, 2 in this. 2, 2, 2. 2 samples, 2 weeks and 2 months. Got my point? 2, 2, 2. And the transport temperature is also very easy to remember. 2 to 8 degrees. That is why we call it as reverse cold chain. Cold chain vaccines, they come from higher to lower level, but this is reverse cold chain, going from the lower levels to higher levels. Got my point? Yes. 60th day, we have to go and check for wasting. That is called as residual paralysis, residual weakness in the muscle. Usually in the thigh, mid-thigh circumference we take. And after collection and transportation, when you are sending to the lab, it will reach lab within 72 hours. That is a guideline. They will be giving the report for you. But any case of acute flaccid paralysis, we have to give the report as positive or negative within 90 days. After that, no use. So repeat my words. all the cases should be confirmed as polio, yes, no, within how many days? 90 days from the point of paralysis. We have to diagnose as polio or not within 90 days. Indicators, you should remember two things बेटा. Good. One is non-polio AFP rate. मतलब AFP कुछ भी हो सकता है ना. What is AFP? Transverse myelitis, traumatic neuritis. It can be anything. But you have to detect AFP cases. At least 2 cases per 1 lakh population. There are so many cases, I'm telling. Around 4, 5, sometimes 7, 8 cases will happen. Guillain-Barré syndrome, transverse myelitis, trauma is very much common, but identified 2 cases. Before the guideline was 1, now we are telling 1, no, it is 2. Keep it in mind, it is 2. 2 cases per 1 lakh population you have to detect. This will tell whether you are doing surveillance properly or not. What is an indicator to assess operational efficiency of surveillance? What is an indicator to assess operational efficiency of surveillance? Answer is non-polio AFP rate. Non-polio AFP rate. Adequate sample collection is done from 80% of the cases. This is the guideline. You have to collect samples properly. Adequate sample collection should be done from 80% of the cases. This is the number what we are giving. You cannot achieve this target in 100% of the cases. That is why we are giving achieve this target in at least 80% of the cases. What is adequate sample? 2 samples to be collected within 2 weeks. Remember the time limit. 2 samples to be collected within 2 weeks, and 1 sample should weigh how much? 8 grams. This adequacy will indicate how good is your sample. Quality of sample collection. Remember my words properly. Quality of sample collection. So quality criteria, quality of sample collection should be done from, like if this is the word, adequate sample collection should be done from 100% of the cases false. How much is the limit? 80. How much is the limit? 80. Good. Leprosy. What we are using in leprosy now is same packs we are using for paucibacillary leprosy and multibacillary leprosy. Remember this word. Same packs we are using. Paucibacillary and multibacillary. Paucibacillary, the treatment is for 6 months. Multibacillary leprosy, the treatment is for 12 months. Got my point? The only thing is the difference in the duration. Paucibacillary leprosy, we use treatment for 6 months. Multibacillary, we are using treatment for 12 months. The drug what is used is same for both. In day 1 we are using RCD. RCD. What is RCD? Rifampicin, clofazimine, dapsone. The patient on day 1 will get RCD. Rifampicin dose is important, 600 mg. The remaining days the patient will get CD. CD. The dose of clofazimine is less, 50 mg. Dapsone is 100 mg. What my point? Dapsone 100 mg. So what the patient will get on day 1? RCD. For the remaining days, CD. Good. RCD. For the remaining days, it is CD. 6 months, 12 months. Chemoprophylaxis within the family. Contacts will be given chemoprophylaxis. Single dose rifampicin. This is the chemoprophylactic regimen. Sparsh campaign is related to leprosy, where they want to create awareness how leprosy spreads. What is the treatment? How many months of treatment? Just basic level of awareness we need to give for leprosy management. So what I want to tell is the mascot used for leprosy awareness, if they want to create awareness, the mascot used is labeled as Sapna. She's a cartoon character actually, na? So Sapna will be leprosy mascot for India. Meena is different. Meena is for girl empowerment. Meena is not related to leprosy. Meena is for girl empowerment, created by UNICEF. A girl with parrot in the right shoulder, like she'll be running, creating that concept of girl empowerment, what has to be done. But Sapna is for mascot used in leprosy campaign, Any posters if you are making, we can use Sapna as a mascot. So you'll be sending the messages in that poster. Syndromic management, very important. STI kits in your exams, especially when you go and solve all the FMG previous year topics. Syndromic management, Suraksha clinics, you cannot skip. STI management is must. The patient will get gray kit if they are having such symptoms. Urethral discharge, anorectal discharge or cervical discharge. Gray kit is used. Azithro and cefixime. We have to remember the drugs also important. Green kit is for vaginal discharge. Only vaginal discharge, I am telling. Secnidazole and fluconazole. We need to suspect some fungal infections. White kit is for non-herpetic ulcer. Remember this. White kit is for non-herpetic ulcer. We'll be using benzathine penicillin and azithromycin. We'll be using benzathine penicillin and azithromycin. Kit 4 is blue color kit, allergic to penicillin. The patient is allergic to penicillin, where kit 3 cannot be used because there is benzathine penicillin. We use doxy plus azithromycin. So repeat: gray, green, good, white, blue. Red kit is herpetic ulcers. Tab icyclovir, so virus, antiviral agent, herpetic ulcers. Lower abdominal pain is yellow kit and inguinal buboset is black kit. So tell me, repeat my words: gray, green, white, blue, red, yellow and black. So total how many kits are there? Total 7 kits. How to remember? Gray, green, initially same alphabet. Then ulcers, you remember the drugs: white, blue, red. Like go green with blue rivers. You can see the rivers flowing. You are going to a greenery, some picnic spot. Go green with blue rivers, and some yellow birds are flying around you. So just imagine the situation: picnic. Go green with blue rivers and yellow birds. So that is total 7 kits. Suraksha clinics, STI management. So rabies, very important guidelines what you should know: post exposure prophylaxis, pre-exposure prophylaxis and re-exposure prophylaxis. After exposure, remember the words properly: after exposure, that is post exposure. Updated Thai Red Cross schedule. It is intradermal schedule. Got my point? Updated Thai Red Cross schedule. It is intradermal schedule, where the patient will get intradermal injections, 0.1 ml intradermal each deltoid. Highlight this word: 0.1 ml intradermal each deltoid. Each deltoid means 2-site schedule. What my point? It is 2-site schedule. How many visits for the patient? 4 visits for the patient. So 2-site schedule, 4 visits for the patient. It is Thai Red Cross schedule. Whatever the schedule what we prefer in India, it is Thai Red Cross schedule only. Nowadays, if they ask what is preferred, it is Thai Red Cross schedule. It is intradermal schedule. How many site? 2 site. How many visits? 4 visit schedule. But there is one more schedule used. What is the schedule used? Called as intramuscular schedule. What is the name of the schedule? SN schedule. So the patient will have 5 visits. Nowadays we are not using in gluteal areas. This has been changed to deltoid. 0.5 ml intramuscular deltoid. Remember this word. How many site? 1 site. 0.5 ml intramuscular deltoid. How many site? 1 site. 5 visits. So 1 visit is extra for the patient. 1 visit is extra for the patient. So Thai schedule 4 visits, SN schedule 5 visits. What is preferred for post exposure? I am asking. Updated Thai Red Cross schedule is preferred. Pre-exposure prophylaxis means those who are at risk of developing rabies, means they are exposed to animals. They have to protect themselves. How many visits? For protecting themselves, I am asking 3 visits 0, 7, 21 or 28. Either the patient will take vaccine on 21st day or 28th day. So it is one site. Either you follow intradermal visits or intramuscular visits. It is one site schedule. Re-exposure means he has been vaccinated before. Again there is dog bite. So there is dog bite again and again. What are you supposed to give for re-exposure prophylaxis? Tell me. If the bite is within 3 months, nothing to worry. No need for any vaccine. The bite is within 3 months, nothing to worry, because if the patient has taken vaccine today and he has completed the schedule, and again there is dog bite within 3 months, nothing to be done. Nothing to be done. After 3 months, highlight this word, 2 visits. Intramuscular schedule you take or intradermal schedule, it is one site only. But the patient will come 2 times to you. No immunoglobulin. This will be the question in the exam. Second time, if the exposure is taken, there is no immunoglobulins. So immunoglobulins will not be necessary if it is repeated exposure. So repeat the word. How many visits in SM schedule? 5. Thai Red Cross schedule? 4. Pre-exposure 3 and re-exposure 2. 5, 4, 3, 2. Remember the words properly. 5, 4, 3, 2. So just how to remember if they ask, very easy. SN has how many letters? 5 letters, 5 visits. Thai has how many letters? 4 letters, 4 visits. Pre-exposure, pre has 3 letters, 3 visits. Re, 2 letters, 2 visits. 2 letters, 2 visits. So the question is 5, 4, 3, 2. Thai schedule 2 site, remaining everything is 1 site. Thai schedule 2 site, remaining everything is 1 site. So got my point? So we are going and doing this rapid revision session. Already there is topics which has been discussed in your regular batches. So it is for FMG what we are doing for exams, rapid revision session. So Crimean Congo hemorrhagic fever. See the words properly. Crimean Congo hemorrhagic fever. What is the reservoir for this? Cattle and camel. Cattle and camel. So C for cattle, C for camel. That is the reservoir. Vector is hard ticks. Remember like this. CCHFN. F for fever. So what is the symptom? Viral hemorrhagic fever. After exposure to cattle, if they mention this word camel, the vector is hard ticks. There is chances of fever, rash, that is viral hemorrhagic fever. Viral hemorrhagic fever. So CCHF will present as viral hemorrhagic fever. Nipah infection is very, very important nowadays. You'll be knowing this. We are having cases in Kerala, West Bengal also. What is happening with Nipah infection is the reservoir will be fruit bats. The reservoir will be fruit bats. What those bats will do, they will consume the fruits and they will drop the fruits now. These pigs will start consuming it. Then pigs will start barking. This was the question. Bat, then pig, and pigs will start barking. Then when those workers who are working with pig farmers are getting affected. This is one route of transmission which happened in Malaysia. So repeat the words. Bat, pig and man. Bat will drop the fruit, pigs will consume, they will start barking, then humans will be affected. Bat, pig, man. One cycle. Or else the second cycle is directly you will be consuming those fruits. You are only consuming it. Or you will be consuming those date palm sap what was having bat urine usually. When you are keeping the container for palm collection, that bats will come and drop the urine in that. You won't be knowing it. Date palms, you'll be using it for sweets, you'll be consuming it like that. It is very sweet, date palms. If you are getting infected now, again there is a risk. You'll be suffering with acute encephalitis. Acute encephalitis. Sometimes there is man-to-man transmission also. They mention this word within the family or within the hospitals. The patients, those who are having encephalitis, are spreading the disease to one more. Because Japanese encephalitis, there is no man-to-man transmission. But here it is man-to-man transmission, because encephalitis can be Nipah, encephalitis can be Japanese encephalitis also. In which there is man-to-man transmission? Nipah. Nipah is very dangerous always. The reservoir is fruit bats. So if they mention this word bats and encephalitis, after exposure to bats there is encephalitis. If they mention this word, you have to suspect Nipah infection. Keep this in mind. You have to suspect Nipah infection. If I say like this, bats, internal bleed and death, you have to suspect Ebola hemorrhagic fever. After exposure to bat secretions, there is internal bleeding, hypotension, shock, death. If they mention such words, you have to suspect Ebola hemorrhagic fever. The differential diagnosis will be yellow fever. What is the differential diagnosis of Nipah? Acute encephalitis. What is the differential diagnosis of Ebola? Hemorrhagic fever. Zika, very recent infections. The vector is Aedes. You will be suffering with fever, rash, conjunctivitis. Fever, rash, conjunctivitis. So what will happen? Complaints of hemorrhagic fever. The main problem with Zika is when pregnant is infected. See the words properly. When pregnant is infected, they will come out and they will present as microcephaly. Any newborn, if it is getting affected now, there is microcephaly, morbidity, mental retardation can happen later, IQ reduction. So what is happening with Zika in pregnancy is very important. There is microcephaly. That is why we ask pregnants to use insecticidal nets during daytime also. Aedes mosquito is daytime biter. Remember the words properly. Aedes mosquito is daytime biter. So we are asking them to use, yes, insecticidal nets during daytime. What is Abhiyan Indradhanush? Tell me good. A for Abhiyan Indradhanush, sanitation. ESI hospitals, every day they are changing bed sheets. Wipcar pattern, 7 days, 7 colors in rainbow. Every day they are changing the bed sheets. So what is the use of Abhiyan Indradhanush? Repeat my words. To promote sanitation. Good. What is Ayushman Bharat scheme? 2 components. One is setting up of health and wellness centers. All the peripheral health centers has to be converted to health and wellness centers. Second is Pradhan Mantri Jan Arogya Yojana. Ayushman Bharat has second component also, that is very, very important, where health insurance is given for selected members, families in our country, depending on their income levels. It is Pradhan Mantri Jan Arogya Yojana, health insurance up to 5 lakh per family per year. Every year they are insured for 5 lakh rupees. What is Antara and what is Chaya? Don't make mistake. Antara, it is progesterone based injectable contraceptive which is given every 3 months once. DMPA injections which is given every 3 months once. But Chaya is Centroman tablets. Before the name was Saheli. Now we have changed the name completely. It is Centroman tablets, which is non-steroidal OCPs. Non-steroidal oral contraceptive pills. ESI benefits, you should know. The main thing I am telling here, because it is rapid revision sessions, what we have told before only, not everything, only very, very important things we'll be discussing. Good, yes. Sickness benefit for 91 days, but extended sickness benefit will cover 34 diseases. How many years? 2 years. Extended sickness benefit will cover 34 diseases. 2 years it will be available. Like if the patient is on TB, chronic tuberculosis treatment, like that, if the mention question, what benefit will cover? The worker labor ESI. It is extended sickness benefit. How much the pregnant will get under ESI? 26 weeks of leave for confinement. Full wage will be compensated. They won't deduct anything. 26 weeks of maternity leave, full wage will be given. 3 days are sanitary pads under menstrual hygiene scheme. This is to promote menstrual hygiene. Kayakalp scheme is promoting sanitation in government hospitals, not in private hospitals. Kayakalp is one initiative where they'll maintain hygienic conditions. Quality checking is there. This scheme is applicable for government hospitals only. Public health facilities means government hospitals, to promote sanitation in government hospitals, not in private hospital. So fertility indicators, again I'm telling, this is very repeatedly asked. When I started the session it was mortality indicators. Now I am discussing fertility indicators. What is the difference between crude birth rate and general fertility rate? See the words properly. What is the difference between crude birth rate and general fertility rate? See the difference in the denominator. It is number of live births per 1000 mid-year population. But here it is number of live births per 1000 women in the reproductive age. So the difference is in the denominator. Crude birth rate, the denominator is mid-year population. Crude birth rate, the denominator is mid-year population. And in general fertility rate, the denominator is reproductive age. Repeat, the denominator is reproductive age group. So that is why they always ask this question, which is better comparatively. General fertility rate is always better because the denominator is reproductive age women. Total fertility rate, gross reproductive rate and net reproductive rate. Don't make mistake in this. Total fertility rate, gross reproductive rate and net reproductive rate. So what is the main difference? Total fertility rate is average number of children per woman, means one woman will have how many children. It will indicate family size. It will indicate family size. See this formula. Crude birth rate depends on total fertility rate. This was the relationship asked in the exam. If total fertility rate is given, what is crude birth rate? This can be one question. 8 times the total fertility rate plus 1. If I say like this, total fertility rate is 3. Total fertility rate is 3. What is crude birth rate? Answer it. Good. 25. Very good. You substitute the value. They will mention this question. If total fertility rate is 3, calculate crude birth rate. Your answer is 25. Gross reproductive rate means only girls we are counting. Total reproductive rate or total fertility rate means both boys and girls. Gross reproductive rate means only girls, means half. It is half of total fertility rate. If total fertility rate is given 2.6 like that, what is gross reproductive rate? 1.3, because it is almost half what we count. Net reproduction rate is number of daughters a newborn will have in the future. See the difference. We are starting from newborn. Number of daughters a newborn will have in the future. Newborn will have in the future, because we are counting both mortality and morbidity. Here fertility and mortality both are considered. A newborn will live till that limit or not. That is what we are checking first. She has to attain that reproductive age, then only she can conceive. Which fertility indicator, which is the best out of everything, is NRR, where you consider both fertility and mortality together. NRR. Keep this in mind, very important. And one more question what we are asking is, what is NRR1? NRR1 indicates replacement level of fertility. NRR1 indicates one girl is donating one more girl. She is getting replaced by one more. It is replacement level of fertility. If at all NRR is less than 1, see the words properly. NRR is less than 1. Population is below replacement level, because replacement level is 1. Couple protection rate will indicate how many are using contraceptives. It is a pie chart to indicate prevalence of contraceptive practice. If they mention this word, proportion of contraceptive usage, prevalence of contraceptive practice, what indicator is used? Answer is couple protection rate. So tell me all the fertility related indicators. crude birth rate, median population, denominator, general fertility rate, reproductive age, total fertility rate is children, gross reproductive rate is girls, net reproduction rate is number of daughters a newborn will have in the future. So couple protection rate is how many are using contraceptives. Total means both boys and girls. G gross girls. N NRR N for newborn. N NRR N for newborn. See this table. You can read the PDFs when I am giving to you. Later I'll be giving to your class coordinators. MCH indicators. Perinatal mortality rate means stillbirth plus early neonate. Around that we count. Stillbirth is starting from 28 weeks in India. The period of viability. Stillbirth plus early neonatal deaths. Denominator is live birth plus stillbirth. If at all they ask for international comparison, the formula is count babies weighing only more than 1 kg. Don't include everyone. Count only babies weighing more than 1 kg, not everyone. Not everyone. Neonatal mortality rate is different. Within 28 days, how many will die? Post neonate is 28 days to 1 year. 28 days to 1 year. When you are adding neonate plus post neonate, we get infant mortality rate. When you are adding neonate plus post neonate, we get infant mortality rate. Infant is within 1 year. Under 5 is within 5 years. Whatever the death which happens. Child survival index formula is this. Under 5 mortality rate is given. And you have to substitute in this formula 1000 minus under 5 mortality rate by 10. This is the formula for child survival index. Child survival index. What is the denominator of neonatal mortality rate calculation? Live births. What is the denominator of infant mortality rate? Live births. Usually we ask calculate infant mortality rate, calculate neonatal mortality rate. The multiplier used is 1000. Don't multiply with 1 lakh. The multiplier used is 1000. Maternal mortality ratio. Ratio means two different entities where you count maternal deaths by live birth. Denominator again it is live birth. Maternal deaths divided by live birth. Multiplier is 1 lakh. What is the multiplier? 1 lakh. For every 1 lakh, how many mothers will sacrifice their lives? This is how you calculate maternal mortality ratio. Death within 42 days. This is the time limit. Death within 42 days. Irrespective of the duration and site. Keep these words in mind. Irrespective of the duration and site. And not from accidental causes. Suicide, homicides will not be counted. So it is within 42 days, first point. And irrespective of duration and site. Ectopic pregnancy is counted, or anything related to pregnancy and its management. If they ask question like cesarean section, negligence, death, they frame this question. Cesarean section, negligence, death, yes, we count. And not from accidental causes. Suicides, homicides, all this will not be considered. This is the way to calculate maternal mortality ratio. And very important topic, it is vitamins in nutrition. So you cannot go to exams without knowing vitamins. What is vitamin B1 deficiency causing? Tell me. Beriberi, Wernicke's encephalopathy. What are the types of beriberi? Dry and wet. Dry beriberi presents as peripheral neuropathy. Wet beriberi presents as congestive cardiac failure. Dry beriberi peripheral neuropathy. Wet beriberi congestive cardiac failure. Wernicke's encephalopathy will present as GOA is the mnemonic, global confusion, ophthalmoplegia, ataxia. Global confusion, ophthalmoplegia and ataxia. Riboflavin deficiency will be knowing it will affect the lips, angles, angular stomatitis. Niacin will cause, like niacin deficiency will cause pellagra. What are the D's in pellagra? Repeat my words. Diarrhea, dermatitis and dementia. Diarrhea, dermatitis and dementia. Glossitis in pellagra, there is loss of papillae. Dermatitis, Castle's necklace, there is excoriations around the neck. Maize and jowar consumption will cause pellagra because maize there is lack of tryptophan. Always you know this point. Remember, tryptophan is converted to niacin. Keep this in mind. Tryptophan is converted to niacin. If there is no tryptophan, there is niacin deficiency. That is why there is pellagra. And jowar is rich in leucine. Excess of leucine will block the conversion. Excess of leucine will block the conversion from tryptophan to niacin. So jowar is rich in leucine, so it will block the conversion from tryptophan to niacin. Pantothenic acid and pyridoxine, almost symptoms similar. B5 will also cause burning feet syndrome and B6 will also cause peripheral neuropathy. But the question is, isoniazid will cause B6 deficiency. Patient on TB treatment, they'll frame a question like this. Tingling sensation in the feet, what drug is responsible? Isoniazid. What supplements we should give? B6 supplements. Folic acid, megaloblastic anemia. B12 deficiency is seen in vegetarians. Exclusively veg, if they ask questions like this, B12 deficiency. Pernicious anemia. Vitamin E, vitamin K. Don't confuse between them. Vitamin E is antioxidant. If there is no antioxidant, oxidation free radicals can lead to hemolysis. Oxidation free radicals can lead to hemolysis. Vitamin K deficiency can lead to hemorrhagic disease of newborn because newborns, they are prone for bleeding manifestation. That is why we advise them to take vitamin K1 injection. We advise all the health workers to give vitamin K1 injection at birth. They mention this word, vitamin K1 injection at birth can prevent hemorrhagic disease of newborn. Vitamin K1 at birth, hemorrhagic disease of newborn. Keep this in mind. HDN, vitamin K1 injection at birth can prevent hemorrhagic disease of newborn. Anemia Mukt Bharat, very important guidelines. Which age group will get what? You should know this. Anemia Mukt Bharat. What is the supplementation in different age groups in Anemia Mukt Bharat? If they frame this question, starting from 6 months to 5 years. Starting from 6 months to 5 years. If the age group is like this, we give IML, like what is that? IFA syrup. It is 1 ml IFA syrup. 1 ml IFA syrup. The composition of 1 ml is 20/100. Highlight this number. 20/100. 1 ml IFA syrup will have 20 mg of elemental iron, 100 microgram folic acid. So we are giving bi-weekly, means in a week twice. 5 to 9 years, pink color tablet weekly once. Pink color tablet weekly once. What is the composition of pink tablet? It is 45/400. 45/400. Adolescents will get blue color tablet weekly once. The composition of blue color tablet is very important. 60/500. Because in pregnancy also we are using same dose, but the color is different. Red color tablets, the dose is 60/500 only. Starting from second trimester, we start and give 6 months, 6 months. Remember the time limit. 6 months, 6 months. 6 months in the second trimester till pregnancy, delivery. After that also we are giving iron folic acid supplementation. So total 180 days, 180 days. This was the question. Color red. Daily once. Dose 60/500. Dose is 60/500. So this is for pregnant and lactating women. If there is mild anemia, they will get 2 tablets. If they are given orally, mild anemia, they will be getting 2 tablets. But here it is prophylaxis. Anemia Mukt Bharat, it is for prophylaxis. Reproductive women will get weekly once red color tablet. So this is for Anemia Mukt Bharat. What the pregnant will get? Daily 1 red color tablet. What the women, reproductive women will get? Weekly once red color tablets. Weekly once red color tablet. So there is a question on food adulteration for you. When you come across the old previous year topics in FMG exams, food adulteration is very, very important, where they'll be asking so many questions on this. Neurolaterism, how it presents spasticity, spastic paralysis. The dal responsible is Lathyrus sativus. Lathyrus sativus. The toxin is beta oxalyl aminoalanine. So repeat the words, beta oxalyl aminoalanine. So there is spasticity. There is spasticity. How the patients will present? Sticks. They'll be using sticks. Very good. No stick. Then they need one stick to walk from place to place. Then they'll be using two sticks. Later, they cannot move from place to place. They'll be using crawlers to move from place to place. Then we advise not to consume this dal. Use vitamin C prophylaxis. First thing what we advise, or use these procedures. Steeping or boiling has to be done. Steeping and parboiling. These two food processing techniques will remove this toxin. What is the toxin responsible? BOA. How to remove this? Steeping, parboiling. Adding argemone to mustard oil. Argemone is the adulterant. We should not use it. There is a toxin which is sanguinarine. When you are using argemone oil, so what will happen with this is, there is pedal edema, cardiac failures will happen, and sometimes glaucoma. Usually when they ask pedal edema, it is bilateral pedal edema, bilateral pitting edema. One more thing what you should know, it is bilateral pitting pedal edema. And that is why when you are suspecting some adulteration, you can complain to the food inspectors. Food inspectors will go and check the samples in the shops nearby, those who are doing adulteration. Nitric acid test is most commonly done, but paper chromatography test is most sensitive. If they are adding in small amounts, we have to use paper chromatography test. Endemic ascites is different from epidemic dropsy. Endemic ascites, what is happening? Crotalaria seeds. When they are getting mixed with other grains, once you consume this, they are having hepatotoxic alkaloids. There will be jaundice and ascites, especially in the tribal areas. So we do health education. De-weeding has to be done. So we do health education. We ask them to do de-weeding. Aflatoxicosis, it is because of aspergillus fungus which grows on moisture. Usually when there is groundnut or something you are storing, that black fungus which grows on that is aspergillus. It is hepatotoxic. When you are using the same fungus for consumption by mistake, it is leading to hepatocellular carcinomas also. Sometimes it can lead to cancers. That is what the question was. Hepatocellular carcinomas also. Better ask them to avoid moisture. Proper storage conditions are must. Warehouse, storage, godowns, when you are keeping, storage conditions are very, very important. So that is why what I am asking is, storage conditions are very important to prevent which fungus. If they ask, it is aflatoxins. Aflatoxins are released by aspergillus. Aflatoxins, it is released by aspergillus. Claviceps is storage fungus? No. Claviceps is field fungus which grows on bajra, rye, if they mention these words. Small black fungus which accumulate on those in the field only when they are growing it. If you consume this, chronic consumption can lead to vasoconstriction. There is pain, tingling, burning sensation in the feet. These words will be used. Ask them to float those seeds in salt water. Salt flotation technique can help in preventing ergotism. Answer is correct. Salt flotation technique can help in preventing ergotism. That is also correct. So coming to the next part, when they are asking questions, usually the two questions which are framed, one is healthcare and the other is biomedical waste. Those two things are the last two things for you. Healthcare and biomedical waste. There are three levels of healthcare: sub-center, primary health center and community health centers. So these are the topics which are important for screening exams, FMGE exams I'm telling. Level of care. Sub-center and primary health center will give primary care, but CHCs will give secondary care because there is specialist. Health workers work at sub-center, doctors work at primary health center. The population is very important, you should know. Especially for primary health centers, the population in plains and hilly tribal areas, you should know. There is no inpatient beds in sub-center, but there are inpatient beds in primary health center and community health center. The first referral unit means the first place to conduct emergency cesarean section. The first place to conduct emergency cesarean section, that is community health center, because there is a specialist to do that. And when you classify sub-center A and B, it is based on the number of deliveries conducted. No deliveries in sub-center A, sub-center B conducts less than 10 deliveries. So primary health center A less than 20, primary health center B more than 20. That means which sub-center conducts deliveries? Sub-center B. That is why this is called as MCH sub-center. Mother and Child Health Sub-Center. There is no classification for CHC like that. CHC A, CHC B like that. We don't classify community health centers. So one more important last point, last topic in FMG screening you should know in PSM is biomedical waste properly. There are 4 bags: yellow, red, white, blue. Yellow bags, remember, it is infectious waste. What will be there? Like human anatomical waste like placenta, amputated limbs, animal waste used for experiments, anything which is soiled with blood and body fluids like swabs, linens. Cytotoxic word, if it is there, it is yellow bag, remember. Chemical liquid, last time question, X-ray films, yellow bag. Blood bag, blood is red, so it will go in yellow. Remember, like this, blood is red, it will go in yellow. Culture, living organisms present, yellow bag. Used mask, N95, where you will throw if they ask, it is yellow bag. So usually yellow bag question is repeatedly asked in the exam because that is very dangerous. We need to burn it. Incineration is done. Red bag is TRP, tube rubber plastics. Tube rubber plastics like catheters, IV tubes, urine bags, remember. Syringe without any needles. Yes. Goggles, gloves with blood also will go in red only. Gloves, it is contaminated with blood, then also it will go in red only because we need to autoclave, we cannot incinerate. White color is for sharps, something which will prick you or cut you, something which can prick or cut. We have to use white color. Puncture proof containers. And if they ask blue cardboard box, it is for glass and metals. Any metallic implants, it will go in blue. And any glass, broken, unbroken, if it is glass, it is blue. Only if they ask question, glass with cytotoxic waste, ampules with cytotoxic waste, then only mark yellow. What my point? Yellow, red, white, blue. What is for blue? Glass, either broken, unbroken. But if glass with cytotoxic waste, yellow color. And metallic implants will go in blue box, that is cardboard box with blue marking, what they say. So these are some questions which was supposed to be covered under FMG rapid revision session based on your exams which are important for PSM. So I have covered all the important topics based on the screening exams. I'm telling again. So any doubt, you can use my Instagram handle and you can ask me the doubt, Rajeev Shetty. And use my Instagram handle and you can ask me any doubts in this. So PDFs, whatever I have discussed in the PPT part, I'll be giving it to the class coordinators. So you can collect it from them. So any doubt, you can use my Instagram handle, Rajeev Shetty. So all the best for your exams. Hope it is like with this rapid revision session. Obviously, it is not a classroom session. It is revision sessions only, where it will be in rapid mode only, because I don't want to waste your time, because whenever there is revision, you have to stress more on the points which are important, keywords which are very, very important. So this is the concise session, rapid revision session for screening exams what you have planned for, and there are many other subjects where they'll be discussing rapid revision parts for different subjects also. So all the best. Thank you so much.